My name is Roxanne Kainajad. I am a trainee psychiatrist in London in the UK, and I am the founder of a network called the International Violence, Abuse and Mental Health Network, or iVAMHN. I'd like to really warmly welcome you to this, which is our first online conference, and I really want to thank you all for making the time to join live. I know very well how easy it is to register for a conference and then think you'll watch the recordings later, and how hard it is to actually find the time to do that. So we really value you being here live and want to thank you for being here. It means a lot to us. I'll just tell you briefly about iVAMHN and what this network is. iVAMHN arose from a recognition that the intersection of violence, abuse and mental health is understudied in low and middle income countries. I applied for funding from King's College London for an ODA Research Partnership Seed Fund grant, a Global Engagement Partnership Fund grant, and money from the King's School of Mental Health and Psychological Sciences, and they have generously funded this network. We're also affiliated to a network called iVAMHN, which is funded by UKRI. We have so far held one in-person conference in 2019, and that led to a publication of a paper on priorities for the field of gender-based violence and mental health in low middle-income countries. That came out of a survey that we ran of our members. Today's meeting was inspired by an event some of you might have attended in March, the Maternal Mental Health Across Africa Symposium that was organised by the Global and African Alliances for Maternal Mental Health. That is where Daruwalla, the co-organiser of this event, and me met in a breakout room discussing intimate partner violence. After a year of coronavirus restrictions, that meeting that we met in really reminded us how inspiring a really good quality conference can be. And we spoke and we said we should organise an event just focusing on this particular subject of gender-based violence and mental health, with a focus on evidence from low and middle income countries. And that's where we are today. We hope that the Q&A and panel discussions will be particularly dynamic and engaging, and we especially hope that your breakout rooms will be a chance for you to meet future collaborators. Given that mental health conditions and gender-based violence are known to be highly prevalent, it's really important that we recognise many of us in this virtual room may ourselves have lived experience of one or both of these. This meeting is a safe space, and we encourage you to step out if you need a break from any of the content. We also encourage all delegates to feel at home, but also to speak respectfully and not disclose any confidential information in this public forum. Please only use social media to tweet supportively, and don't share any content outside this meeting if it pertains to any particular individual's lived experience. We've been delighted by the high number of registrations for this meeting, and because of this, we haven't been able to have a separate facilitator in every breakout room. So before those breakout rooms, we're going to share with you a list of discussion topics beforehand. And if one member of the room can keep notes of what you discuss and send them to me, that will hugely help iVAMHN to organise events and activities in the future that meet your priorities. This meeting is being recorded, but the breakout rooms won't be, just for you to be aware. However, we do believe that attending conferences live is much more enjoyable and effective than watching recordings later, so please stay with us throughout the day. Lastly, we'd love to keep in touch with you, but strict data protection rules mean you need to give us your permission to be added to our mailing list. You'll be able to join through the link I'm going to share at the end of the day. And we also are conducting a survey on relationships and well-being during COVID-19. I'll also share a link to that, and it would be a huge help to us if you could complete it. Finally, as we said to the early registrants, do please introduce yourselves in the chat. Feel free to share your thoughts on the conference on Twitter, for example. I'll post in the chat what our Twitter account is and a hashtag. And above all, please enjoy the day.
Good morning. Good morning. My name is Dr. Daruwalla, a lecturer at the University of Ghana and a co-organizer for this event. I wish you all a warm welcome to this online interactive event on gender-based violence and mental health. Gender-based violence comprises of acts of violence that are meant to harm people because of their gender. with the declaration of COVID-19 as a pandemic, there has been a surge in gender-based violence worldwide. And this is so because the measures that were deployed to curb the spread of the virus has inadvertently led to its increase. This is worrying in the light of the devastating effects of gender-based violence on individuals, especially in terms of their mental health. Because even when the physical effect diminishes, the mental health toll endures. Thankfully, today we have an array of experts who are going to help us to unpack the issues and to gain clarity. Our keynote speaker for today is in the person of Professor Angela Ofori-Atta. She's an experienced clinical psychologist, distinguished in Ghana and beyond. She's also the head of Department of Psychiatry, Korle Teaching Hospital, and the director of PsychCore, a program for psychology graduates to help them to deploy mental health aid across the communities in which they live. She advocated strongly for the passage of Ghana's mental health law, which was passed in 2012, and she is currently the host of Beautiful Minds, a radio program that is meant to build resilience. Please help me to welcome Professor Angela Ofori-Atta to deliver her keynote address on the interactions between violence, abuse, and mental health in Ghana. Thank you very much.
Hello, my name is Professor Ofori-Atta from the University of Ghana Medical School, and it's a real pleasure to be here with you. It is an honor indeed and a privilege to be invited to give the keynote address at this august virtual meeting. I am reminded of the people with whom I have worked over the past 30 years, and I would like to dedicate this keynote address to them for the many things they have taught me. One, that they can heal in spite of the brokenness with which they begin therapy. That in spite of the abuse that they have suffered, they are not all angry and bitter. That when they are ready, they move on to better lives. And fourthly, that all I have to do is to provide the knowledge and be there to listen and hold their hands through the journey, and they do the rest. I'm grateful for the lessons, and I pray that the impact of therapy on their mental health, which they have mostly reported as positive, lasts long after we have said our goodbyes. I also dedicate this to the many policemen who undertook the gender sensitization training, which my colleague, Dr. Arva Sefadide, and I gave in the early to mid 1990s, when the domestic violence units of the police were first set up. We struggled to understand each other, and I watched fascinated as they struggled to overcome the cultural straitjackets of masculinity and powerlessness associated with women, even as they praised their own mothers and sisters for their strength as overcomers of abusive relationships. We butted heads through 4-day training sessions at a time and ended up with a slightly better understanding of each other's different perceptions of gender issues and what constitutes gender-based violence. I pray that the struggle stayed with them for years, as it did with me. So I'd like to share my screen right now with you. If you just give me a minute. Here we are. Okay. So the structure of my address today will be first the definition of gender-based violence I would like to adopt for this keynote, forms of gender-based violence, prevalence, focus more on child sexual abuse, attempted and completed rapes. I'd like to talk a little bit about likely perpetrators, talk about psychological impacts and physical impacts of gender-based violence, And then I'd like to spend a little bit of time on interventions, both for individuals and for communities. Now, gender-based violence is a pervasive problem, as you all are aware. And as of 2020, the United Nations reported that violence against women was a major public health hazard or concern, affecting approximately 1 in 3 women globally. And from another such report by the WHO in 2018, the prevalence of lifetime intimate partner violence ranged from 20% in the Western Pacific to highs of 33% in Africa and Southeast Asia in the past decade. Factors which increase the risk of perpetration and experience of gender-based violence include having low education, alcohol and other substance use cultural norms, relationship discord, history of exposure to parental violence, and violence during childhood and toxic masculinity. In humanitarian settings after disasters, other factors come into play, such as membership in a minority clan or group. Determines who has protection and who doesn't, I guess. When asked, women survivors of gender-based violence consistently report negative impacts on physical, mental, and reproductive health. Often, negative health and social consequences are never addressed because women do not disclose gender-based violence to providers, nor do they access health care or other services. For example, protection, legal services, traditional authorities. This lack of accessing care is because of social norms that blame the woman for the assault. For example, she was out alone after dark, she was not modestly dressed, she's working outside the home when she should be at home, and so on. Also, norms that prioritize protecting family honor over the safety of the survivor inhibit accessing care. So how shall we define gender-based violence? We could use the Interagency Standing Committee's 2015 definition of gender-based violence as any harmful act that is perpetrated against a person's will, and that is based on socially ascribed differences between females and males. It includes acts that inflict physical, sexual, or mental harm or suffering. Threats of such acts, coercion, and other deprivations of liberty. These harmful acts can occur in public and in private. There are different types of gender-based violence, sexual abuse and rape, including within a relationship. There's physical violence, there's financial abuse, there's taking control over someone's everyday life. For example, when they go, where they go and what they wear, there's monitoring or controlling someone's emails, text messages, or social media accounts. There's threats to kill or harm. There is harassment and stalking. And then there are those forms of abuse that you may find mainly family related kinds of abuses, like forced marriages or female genital mutilation or so-called honor-based abuse. And it would be impossible to focus on each and every one of these. And so I'm going to choose to talk about just a few of them, as you've noticed in the content. So let me just focus for a minute on the prevalence of gender-based violence in Ghana. Now, these statistics are mainly collected by the police through domestic violence and victim support units across the country, and the numbers are at best patchy. So in 2011, the police reported 12,906 cases of various forms of violence against women and girls, including physical assault, sexual assault, and murder inflicted by intimate partners. Then in 2014, out of the 17,655 domestic violence cases reported, 7.3% were cases of defilement and 1.8% were rape cases. We can assume that the vast majority of reported cases had to do with physical abuse of spouses and children, as well as neglect. The 2015 official report on domestic violence in Ghana indicated that 30% of women and 23.1% of men experience sexual violence at least once in their lifetime, and 10.6% of women and 9.6% of men reported having experienced sexual violence at least once over the past 12 months. These numbers are pretty shocking in community type surveys. And of course, for most of us working in the field, knowing that 9.5% of men report having experienced some form of sexual violence is beginning to, take hold of our minds and say, we better be watching out, looking out for our young boys and teenagers as well. So let's talk a little bit about childhood sexual abuse. Childhood sexual abuse includes any sexual activities with a child below the age of consent. As children are considered unable to freely agree to sexual activities, any sex with a child, and any sex with a child by an adult is non-consensual by definition. It is important to note that from a legal standpoint, the age of consent, that is the age in which individuals are seen as legally competent to consent to sexual contact, varies across countries. For example, the majority of countries in Europe set the age of consent between 14 and 16 years, although there are some notable exceptions, such as France, which has no legally defined age of consent. In contrast, Ghana's recognized age of consent is 16 years. Now, in 2013, the Domestic Violence and Victim Support Unit, DOVSU, of the Ghana Police reported that Ghana had 1,228 reported cases of child sexual assault. And this number we will come back to, this very low reporting of child sexual abuse. There are, however, troubling cultural environments which unintentionally enable child sexual abuse in some of our poorer community settings. Dr. Atta's description of how children are raised together in the extended family in the Krobo areas of the Eastern region, for instance, who sleep in the same room as older cousins and siblings without parental supervision, and thus get introduced to sex much earlier, either through witnessing older cousins or themselves being taught, makes for early sexualization of children with possible impacts on mental health, such as early pregnancy, school dropout, low self-esteem, and poor grades. Another researcher, Markway, in 2020, put out a series of papers which followed girls who had been raped within their communities or who were known to have had transactional sex, usually because of neglect by their families, described heartbreaking evidence of stigmatization, blame of the child, and lack of justice or care for the hurt child. These are known factors associated with anxiety, depression, dissociation, later substance abuse, attachment issues, and adulthood intimacy problems, not to mention a host of physical infections, STDs, HIV, AIDS, and so on, and years of physical pain. Let's talk about attempted and completed rapes now. Attempted and completed rapes are generally considered to be two of the most serious forms of sexual assault. Attempted rape involves a non-successful attempt to engage in vaginal, anal, or oral penetrative sex, whereas completed rape involves vaginal, anal, or oral penetrative sex, including penetration with fingers, objects, or a penis. There is often the use of threats or physical force and/or exploitation of the other's inability to give consent or show active resistance, for instance, due to alcohol intoxication or other substance use. For male victims, attempted and completed rape also includes instances in which the victim is forced to penetrate or attempt to penetrate the perpetrator. Finally, any instance of attempted or completed penetrative sex against someone who is constitutionally not capable of consenting would also be classified as attempted or completed rape. The mental effects of rape and attempted rapes are similar to those of child sexual abuse as enumerated above, effects of which last longer and may be more severe if unattended to. And in 2013, the Domestic Violence and Victims Support Unit of the Ghana Police reported that Ghana had 41 reported cases of attempted rape and 312 reported cases of rape. For a population of approximately 25 million at the time, these figures represent a gross underreporting of gender-based violence. There may be even more cases reported in the general lists of crimes by other police units not directly affiliated with the DOSU or domestic, the special units for domestic violence and gender-based violence. What are the reasons for underreporting of gender-based violence? According to Boateng and Lee, reasons for not reporting included when women considered the incident not serious enough, or perpetrators were known to the victims, and also when the family decides to solve the problem. However, female sexual assault victims who reported incidents to the police did so because they wanted offenders to be caught and punished. The authors showed that the type of sexual assault, education, and age of the victim were significantly correlated with reporting of sexual assault to the police by victims. Other studies indicate that fear of stigma, self-blame by victims, unhealthy attitudes by police, and a lack of knowledge of police services or trust for the police deter people from reporting. So the question is, who is a likely perpetrator? Well, Chewa, in a population-based study of 4 districts in the central region of Ghana, reported that a total of 328 men, or almost 17% of her sample, had perpetrated some form of sexual violence in the past 12 months, with their lifetime prevalence at 27.8%. The researchers added that the experience of violence in childhood and/or witnessing risky behavior and gender inequitable attitudes are the major risk factors for sexual or physical intimate partner violence perpetration. In another study by Boateng of 264 male juveniles aged 12 to 18, a fifth had committed a sexual offense. Behaviors such as paying for sex constituted an important risk marker for juvenile sexual offending, as well as parental neglect, parental conflict, alcoholic parents, parental abuse, and deprived family economic conditions. We may rehash the factors stated above, such as the abuse of substances, toxic masculinity, and other cultural beliefs about the place of women. What are the mental health implications of GBV? There are many. We have mentioned some already, but experiencing various forms of gender-based violence is associated with great risk for mental ill health. There are several studies such as Dworkin et al. And so on, Oram, Khalife, and Howard in 2017, all have affirmed that sexual assault increases risk for most domains of psychopathology, including trauma and stressor-related disorders, anxiety, depression, suicidality, bipolar disorder, eating disorder, substance use, and obsessive compulsive disorder. In fact, there are some clinical populations who report child sexual abuse. For example, 40 to 70% of pain clinics in obstetrics and gynecology, eating disorders clinic, if you were to take a survey or poll of those clinics, you would find a report of 40 to 70% of patients there have experienced some form of sexual violence. The research has further indicated that post-traumatic stress disorder and suicidality were the negative mental health outcomes most strongly associated with sexual assault. 3 clusters of post-traumatic stress disorder most relevant to this discussion are the re-experiencing of intrusive thoughts and emotions, distorted thoughts about the cause or consequences of the event, and changes in biological, emotional, or cognitive arousal. This may include, for example, behaving recklessly or in a self-destructive way, being overly watchful, overly jumpy, if you like. Many victims also experience comorbid mental health conditions such as depression and increased risk for suicide. Researchers have also found a bidirectional relationship between having a rape history and risk for substance use disorders. In turn, substance use disorders are associated with increased risk for rape victimization, particularly substance-facilitated and incapacitated assaults. Also, rape victims may develop substance use disorders as a result of using substances to cope with the aftermath of the event. So let's talk a little bit about physical impacts of gender-based violence. In addition to mental health outcomes, gender-based violence is also associated with many negative physical outcomes. For example, experiencing rape has been linked to sexually transmitted infections, menstrual irregularities, and chronic pelvic pain. In settings with high HIV prevalence, rape victims are also at higher risk of HIV infection. Victims also experience higher levels of general physical complaints, such as headaches and stomach ache. Experiencing gender-based violence is also associated with elevated stress-related psychosomatic symptoms, including headaches, muscle pains, nausea, and gastrointestinal disorders, respiratory problems, weight changes, fatigue, heart palpitations, and insomnia. Treating victims of sexual assault. It is important to make treatments available to victims that are able to address the range of symptoms they may experience. Beyond medical intervention, psychotherapy, can reduce symptoms of both PTSD and related conditions in adult victims of childhood sexual abuse and various forms of sexual assault. Several evidence-based psychotherapies are effective in treating symptoms related to sexual victimization experiences, with the majority of extant treatments focused on addressing PTSD symptomology, specifically trauma-based or trauma-focused CBT-based therapies like prolonged exposure PE and cognitive processing therapy CPT have been associated with reductions in psychological symptoms. These benefits are maintained even 5 to 10 years after the end of treatment. Community-based interventions. At the core of this discussion is the relationship between gender-based violence and mental health. Between these two, there are several tangible and intangibles that need to be tackled. Healthy beliefs regarding masculinity and femininity, the role and regulation of substance use in communities, protection of vulnerable children and interventions for vulnerable families, use of formal education to impact social issues in their communities, expansion of roles of traditional authority and members of parliament, and the re-education of spiritual authority on sexuality. Reporting of abuse is important, either to obvious outlets such as police, one's spiritual leaders, traditional authority, strong family members, and so on. The difficulties, the powerlessness inherent in these community systems, which have not been properly educated about the harm and causes of gender-based violence. Reporting abuse, as we have already talked about, is hampered by lack of awareness of services available to victims of domestic violence, or who doubt that police could handle cases of intimate partner violence. Other barriers to reporting include shame, financial constraints, lower education, and so on. Now, the mounting of social awareness campaigns focusing on the need for prevention, compassion, and care for victims, and justice through community radio and social media would be another effective tool in reducing the incidence and mental health impacts of gender-based violence. It would be remiss of me not to mention the importance of community clinics that provide the examinations that are required to validate and first of all to treat victims of gender-based violence, and secondly to validate what has happened to them and therefore provide evidence to courts for perpetrators to be to be prosecuted. Now, NGOs or non-governmental organizations or community-based organizations such as FIDA and the ARC Foundation provide free legal aid services and temporary shelter, medical and other referrals and rehabilitation to victims of gender-based violence, especially women and children. The importance of sanctuaries cannot be overstated. Thank you, and wishing us all a great meeting.
Hello, everyone. It's so good to be here with all of you, learning and discussing issues that affect so many people around the world, and we continue to learn more. Our next presenter is in the person of Professor Parveen Ali. Professor Ali is a professor in nursing at the University of Sheffield. She is a registered nurse midwife, a registered nurse teacher, a senior fellow of Higher Education Academy, and a fellow of the Faculty of Public Health. Professor Ali is editor-in-chief of the International Nursing Review. She is an editorial board member of the Journal of Advanced Nursing and Journal of Interpersonal Violence. She is an a visiting professor at Dar University of Health Sciences, Karachi, Pakistan, and the Kaifa Medical University, Peshawar, Pakistan. Professor Ali is a mixed method researcher, and her research focuses on gender-based violence, domestic violence, women's experiences of abuse and the support they receive from health providers, as well as social care professionals' preparation. She has led and contributed to many different projects over the past decade. Professor Parveen Ali is a leading voice in terms of gender-based violence research. Let's listen and gain some insights from her.
Good morning, everyone. I hope you all are well. Thank you so much for being here today and for giving me this opportunity to talk to you about this particular aspect, which is very close to my heart. So today we are going to look at the mental health impact and access to health and social care services for women victims of intimate partner violence. We all know that intimate partner violence is a major public health and social problem. And as you all are aware what intimate partner violence is, so I'm not going to go into the definitional detail of it, because I understand that you all understand that it can take many different forms. It can affect women as well as men. Women can also be perpetrators of abuse. Having said that, majority of the cases and it's men who perpetrate abuse against their female partners, and women seems to be experiencing abuse which is much more severe, systematic, consistent, and result in a lot of injuries. We do talk about physical and psychological impacts of intimate partner violence. However, I don't think that we actually really understand the gravity of the issue and what kind of mental health impacts or mental health issues women experience when they are seeking support from different services, be it health and social care services, be it from their healthcare professionals in the GP surgery or into the secondary care hospitals. If they are inpatient, it could be any of those settings. It could be through social workers, or it could also be when they are trying to seek support from police or judicial system, legal system, and when they are going to the court processes. So any of those sorts of journeys are always affected by how women are perceived in those places and how their mental health is. And what I'm trying to say, what is the impact of the experiences of going through all these services on their mental health as well. So I think both of those aspects are quite important to understand, and I don't think we have paid enough attention on these aspects in terms of exploring what is it which we can do to improve women's experiences, and actually what is the actual problem. If we do not really understand the gravity of the situation or the problem which is there, I think it is very, very difficult to then think of any interventions that can be developed to tackle the problem. So that's what we are going to talk about today. So the idea of or the learning in this for this presentation is coming from various strands of work which I've been involved in, and especially the recent work which I have done with colleagues from various different countries under the umbrella of World University Network funded project. So the project aimed to better understand mental health impact of intimate partner violence on diverse women victims. And we also wanted to look at the interventions which are aimed at reducing mental health impact of IPV, including the role of families to support prevention of domestic abuse. So this was one of the projects which started just at the start of COVID in early 2020, around January time. So it was seriously impacted by how the COVID affected all over the world. So we had to stop the project for some time, where initially we just thought that, you know, things would get better and people would be able to get back to their normal lives within a few months, which didn't happen. And then we had to start again. We had to kind of think of the alternative strategies that what we had actually planned earlier on, because as you all know, that because of COVID, all of that we had planned was not really possible. So there were quite a lot of different partners from various different institutions and from different countries, and I'm going to tell you a little bit about that. But our aims were to forge a dynamic interdisciplinary network of scholars who can explore the issue of intimate partner violence and especially the mental health impacts of it. We wanted to conduct a scoping review of IPV experiences of women and the mental health impact on victims to more culturally and geographically diverse populations across the world. We also wanted to conduct a research prioritization exercise with relevant stakeholders in different countries where our partners were, again, to understand the IPV experiences of women and how it was affecting their mental health. And we wanted to conduct workshops exploring the methodological challenges and approaches affecting work in this particular field. And we wanted to foster the development of PhD students and early career researchers. So these were some of the objectives that we had for our network, which was composed of partners from various different countries and universities, including University of Auckland, Bristol, Ghana, Maastricht, Massachusetts Amherst, University of Sheffield, and University of Sydney and Western Australia. So there were quite a lot of colleagues from all these universities. So we were about 15, 16 individuals in the group. So it was quite a big network of colleagues coming from various different disciplines, including criminology, legal justice systems, social work, sociology, health, and public health, etc. So the idea was that we were going to have a look at the aspect of IPV and mental health from various different perspectives. So our bigger aim was to look at the access to health and social care services for women victims of intimate partner violence. And underneath that, initially we wanted to have a workshop in Ghana, to have all the colleagues come to Ghana, interact with different agencies there to be able to understand the issue a little bit better. Having said that, due to COVID, we had to change it. And a lot of the work that we then did was based on online activities, Zoom meetings, monthly meetings, review of the literature, secondary analysis of already available data from another study, and discussion between partners as well as with other practitioners. So we looked at 4 various aspects of the problem, and that work was done by 4 of our teams within the project. So we looked at the mental health effects of IPV as understood by law and judges. So looked at the review of the literature and tried and see how law and judges were looking at the mental health effects of IPV and how was that affecting their ability to provide appropriate services to women who were going through the who were accessing support from legal justice system. We also wanted to look at the technology facilitated IPV and its mental health impacts. And for this, we also conducted a review of the available literature to try and see how technology was used or to perpetrate IPV and to resist against it, and what were the mental health impacts of that. We also looked at the repeat victimization and help-seeking experiences of survivors of intimate partner violence who identified as having mental health issues. So we wanted to see that people who already have mental health issues, how they saw how they saw their treatment, how they were treated by health and social care professionals when they tried to seek help, and how they were repeatedly victimized by various different actors, and their experiences not really acknowledged well. And then finally, we also wanted to look at that if when people go to mental health setting with any mental health problems, chances are that they probably would have had experiences of abuse or some kind of traumatic experiences as a child or in previous life. And we wanted to look at if in those settings, the experience of IPV are explored. Are people questioned about if they have had any experience of IPV previously or any other kind of trauma, and is that taken into consideration? So these were the 4 bigger themes that we looked at. So what we learned from all those 4 work. So here, what I'm going to do is just to give you a little bit of kind of condensed information that we learned from all of these projects and working on all of these aspects of the projects and coming up with the themes. So one thing which we looked at is or identified or learned is that the IPV or domestic abuse is not assessed as precursors of mental health issues. So when people access health and social care services, especially in mental health setting, where you would expect that perhaps somebody is going to ask them about their traumatic experiences or anything to do with intimate partner violence, they're usually not asked those questions. So it's one of the big effect of that is that, you know, it just gets missed and nobody's then able to deal with it. There's lack of understanding among professionals. There's lack of understanding of how IPV can result or impact the mental health of the victim, and then how it can be perceived and experienced by the victims, and what are the consequences of it. And at the same time, there's lack of understanding of the impact of processes or services that victim has to go through has an effect on the mental health of victims. So for example, if somebody is going through legal justice system, trying to understand, trying to get out of abusive relationship, they're repeatedly probably asked the same questions about how their relationship was, what kind of abuse they've experienced, which in itself could be quite traumatic. They may not be believed by the people who are asking questions, or they may get a feeling that they are not believed, and they may go through that trauma over and over again. There are quite a lot of times where they have to justify or actually prove that they have been experiencing abuse, and all of that can have quite a lot of impact on the mental health of the victims. And all that happens because various professionals, and which include, if you talk about health and social care system, it's the health and social care professionals, and if you talk about legal justice system, it's the police officers, it's lawyers, it's judges that people deal with regularly. They do not seem to understand the impact domestic abuse can have on somebody, and especially if that person apparently is looking very strong, then it just becomes even more difficult, and you have to, because the person doesn't really fit the persona that people would like to see or stereotype as someone who is experiencing abuse should look like this, and if that person doesn't really fit that persona, it's really difficult for them to then articulate their needs and for others to understand where they're coming from. We learned that the mental health issues are usually used against women victims. So again, I'm going to take the example of legal and justice system. Evidence suggests that in many instances, lawyers would and workers would advise women to not to disclose their mental health issues to the legal and justice system, because it can affect their child custody. So if a woman has got mental health issues, she may be blamed for, or she may be accused of, or considered that she's not going to be able to take care of her children, and therefore it can have an impact on the child custody cases. It can also be used as an excuse or as an acceptance that why a woman is experiencing abuse, because she already has mental health issues, and therefore her behavior would be erratic, and therefore she is being subjected to abuse. And then again, for any of the other aspects related to it, victim blaming is another issue. So she could be accused of not looking after her children, or not protecting her children from abuse, or living in the relationship, or not leaving the relationship, and so on and so forth. Whereas the same thing, the mental health issues, if is talked about by a man, it usually goes in their favor, especially in child custody cases. So, then the whole scenario is switched, and the narrative usually is that because the person has got mental health issues, having custody of the children or having regular contact with children is going to be useful for them, or not having custody of the children or not having regular contact with the children is going to have an impact on the mental health of the person, as well as the children, and therefore they are allowed to stay in contact with their children. It can also be used to rationalize their abusive behavior, that so and so has done this because they are experiencing mental health issues, and therefore they have reacted the way they have reacted, or therefore they have been abusive, or therefore they have committed violence against their partner. So you see that when it is women, it's usually used against them, but when it is men, it's usually used in the favor of them. And I think that finding is, as I say, I've tried to come up with the generic information which we have looked at from all these studies, and which is applicable across the sectors, which is health and social care sector, legal and justice system. And that seems to be is an overarching sort of a cross-cutting theme between going through all of these places. Finally, having mental health issues or experiencing mental health issues as a result of the processes that women are going through can affect women's use of services and help seeking. So if the going through the services and being subjected to the same question about their experiences and how they have experienced abuse in previously can deter women to then engage with the processes, and how they are blamed or how they are made responsible for the issues that they have experienced, or not looking after children, or how it may affect their ability to have the child custody of their children, also deters women from then seeking help and from engaging with the services. We already know that many women do not engage with services because they're scared that their children could be taken away. And I think once they experience the effect of engaging with services on their mental health, because it increases their stress, it may increase their anxiety, depression, they may feel like they have to justify themselves all the time. So all that then has an impact on their ability to engage with the services, or to continue with the process, which then also has an implication that the perpetrators are not convicted. They may not be sentenced, and they may get child custody. They may be successful in getting the child custody, which again then ultimately affects the women who has been experiencing abuse in the whole situation. So what is it which we can do? And I think there are a few recommendations that are important for us to think about, is that we need to listen and believe on victims. We need to listen to the victim and survivor stories and about how they're experiencing abuse and how it has been affecting their mental health. And we need to believe them. We need to research and explore and understand the extent and impact of abuse on mental health of women, and how we can use that evidence to then develop appropriate changes, bring about appropriate changes to the law, or develop policies and implement policies in various different settings where we work, be it health and social care setting, or legal and justice setting, or generally, how generally increasing awareness of the general public. We need to increase the number of women professionals, judges, lawyers, health and social care professionals in various different fields, who can then actually empathize and sympathize with the experiences of women, who can actually understand what women are going through and are able to make appropriate decision. And at the same time, they would have the ability to challenge the assumptions of the colleagues and to bring about changes into the systems in which they are working. We also need to challenge victim blaming related aspects wherever these are happening. And I think if we increase the number of female professionals in each of the profession, and if they are appropriately prepared, hopefully they'll be able to challenge victim blaming related aspects, and things would hopefully change. And finally, we need to train people, we need to train professionals, we need to increase awareness of general public about the issue of intimate partner violence and its impact on mental health, and how engaging with various services can also have an impact on the mental health of the individuals going through. And I think together all of those aspects can be really helpful. So that's my learning from this particular project, and I'll be happy to take any questions. Thank you so much for listening, and I hope this information presentation was useful for you. Please do feel free to ask any questions that you may have. Thank you.
The presentations so far have been amazing, and I'm enjoying each and every one of them. But there is more. Our next speaker is in the person of Professor Charity Akotia. Professor Akotia is a professor of social and community psychology at the Department of Psychology, University of Ghana, Legon. She is the immediate past dean of the School of Social Sciences, University of Ghana. Her main research areas are suicidal behavior in a cultural context and gender role ideology. She has published widely in several international and local peer-reviewed journals. She's currently the co-chair of the Council of National and Regional Representatives of the International Association for Suicide Prevention. For those of us in Ghana, Professor Akotia needs no further introduction. Please help me to welcome her to talk on gender-based violence and suicide. Thank you.
Hello, everyone. My name is Charity Akotia, and I am a professor at the Department of Psychology, University of Ghana. Today, my presentation is on gender-based violence and suicide behavior. Gender-based violence is violence that is directed against a person because of his or her gender, or we can also say that it is violence that affects persons of a particular gender disproportionately. Generally, the impact of violence on women is greater compared to men. For example, injuries, sexual victimization, post-traumatic stress disorder are all considerably higher among women than men. Gender-based violence, or GBV, is a global phenomenon, and it's a problem that poses significant challenges to human rights and health. While GBV or IPV and suicidal behavior are associated, the relationship is not usually direct, or it is not causal. IPV, for example, may disturb one's psychological functioning, which may in turn lead to suicidal behavior. Such disturbances, for example, may include post-traumatic stress disorder, depression, bipolar disorder, and many more. Having said this, I would now like to go on to some statistics that have been provided in the WHO 2021 report on violence against women in order to examine the prevalence of IPV. So when talking about gender-based violence, we can talk about intimate partner violence versus non-partner sexual violence. Intimate partner violence is usually perpetrated by a husband or a former husband for that matter, or a male intimate partner. And it could be either in the form of physical, sexual, psychological, or emotional abuse. And it is said to be the most widespread form of violence against women globally. Sexual violence that is committed by persons other than a parent or former husband or an intimate partner is what is called the non-partner sexual violence. And perpetrators may include male relatives, friends, acquaintances, or strangers. And it is also another form of a common violence that is perpetrated against women. So suicide and gender-based violence are both major public crises, and they are strongly associated. Survivors of GBV are, for example, 2 times likely to attempt suicide multiple times, and cases of murder suicide are most likely to occur in the context of gender-based violence. Now we have before us the prevalence rates of GBV and IPV according to the WHO report. So we can see here that about 26% of women 15 years and over who have been subjected to physical and or sexual violence by a current or former husband or by an intimate partner at least once in their lifetime. And this represents about 641 million ever married or partnered women aged 15 years and above who have experienced physical and or sexual violence at least once since the age of 15. Then we can see also that about 10%, of ever married or partnered women aged 15 years and over have experienced physical and or sexual violence in the past 12 months, while 13% of women aged between 15 and 49 years have ever experienced physical and or sexual abuse in the past 12 months. This also results in about 245 million women who are ever married or partnered women aged 15 years and older who have been subjected to recent physical and or sexual intimate partner violence. The global prevalence estimates of physical and or sexual intimate partner violence indicates that almost 1 in 4 ever married or partnered adolescent girls, in the youngest age cohorts of 15 to 19 years, is estimated to have already been subjected to physical and or sexual violence from an intimate partner at least once in their lifetime. And about 16% of young women aged between 15 and 24 years experienced this violence within the past 12 months. Now we have a global picture here, and we can see the global average of lifetime prevalence of physical and or sexual IPV is 27%, right? 27%, while 13% represent the global average for the past 12 months prevalence of physical and or sexual violence, sexual intimate partner violence. Now, let's look at the figures for the least developed countries. We can see that the average lifetime prevalence for least developed countries is 37%, while that for the past 12 months is 22%. And these averages are more than the global average. So these estimates generally, we can say, show unequivocally that violence against women is pervasive globally. Additionally, the estimates show that GBV abounds in these developed countries compared to more developed countries. But if you look at the map, generally, we can also see that the problem is of global nature, and it occurs in all the continents in the world. We have another slide in front of us, and this has to do with the combined prevalence estimate of IPV and non-partner sexual violence. And on the average, about 736 million women aged 15 years or older in 2018 experienced IPV. So this is almost about 1 in 3 women who have experienced physical and or sexual violence at least once in their lifetime. Thus, these two forms of violence remain pervasive globally in the lives of women and girls. To the extent that its violence against women is captured in the Sustainable Development Goals. So specifically, SDG 5 aims to achieve gender equality and to empower all women and girls. Target 5.2 specifically aims to eliminate all forms of violence against women and girls in the public and private spheres, including trafficking and sexual and other types of exploitation. Now, with these statistics, what do we do with them? I would like us to now, interrogate some papers or some researches that have been conducted over the years to see what are some of the mental health outcomes of gender-based violence. So in 2016, a study was conducted by Oram and his colleagues, and they aim to identify whether there are any mental health outcomes of violence against women. And in their findings, they noted that some of the outcomes include suicide and suicidal behaviors, self-harm, depression, post-traumatic stress disorder, and alcohol abuse. Then in 2017, DeVries et al. Also conducted a systematic review of longitudinal studies. The aim was to establish whether there was any link at all with mental health outcomes when it comes to gender-based violence. And their findings indicate very strong positive association between IPV and depression. They also found that IPV was associated with suicide attempts. And they found that among men, there was no clear evidence of an association between IPV and suicide attempts or depression and incident IPV. And so here we see a clear difference in the mental health outcomes of IPV for men and women. In 2012, a study was conducted by McLaughlin and others to establish whether there is any relationship between intimate partner abuse and suicidality. It was a systematic review. Their findings indicate a very strong and consistent association between intimate partner abuse and suicidal thoughts and behaviors. And these findings were irrespective of the design that was used by the studies, the sample that was used, and the measurements of abuse and suicidality. In 2017, another study was conducted by Castellevi et al. And it was a meta-analysis of longitudinal studies with the aim of assessing the association between gender-based violence and suicide generally. And they found that early exposure to IPV is associated with elevated risks of suicide attempts, and particularly suicide deaths in youth and young adults. They also found that victims of any IPV are 2 times likely of subsequent suicide attempts. Young victims of IPV are 10 times likely to die by suicide. So all along, there have been a kind of association that has been established by research when it comes to suicidal behavior and gender-based violence. Now, another study was conducted by Angela et al. In 2020, and they also established that the various forms of abuse, such as sexual abuse, physical abuse, emotional neglect, and many others, were all significantly associated with higher rates of suicide. In 2018, no, this was in 2021, I think, iVAMHN et al. Conducted a study which took a life course approach. So they wanted to understand the impact of male intimate partner violence on women in a life course perspective. And what did they find? They noted that when the women were in the relationship, they experienced direct impacts on their physical, mental, social, and financial well-being. During separation, many of the women experienced continued abuse and housing, legal, and financial stress. Life after separation was marked by loneliness, trauma, financial insecurity, and damaged relationships. So we can see clearly that irrespective of the stage in which the women were, whether they were in the relationship or it was during separation or even after separation, they still experience some challenges that could impact negatively on their mental health. McIsaac and others in 2018 also examined the coroner's register. They conducted an analysis on the register, in order to establish whether persons who died from suicide actually had been exposed to interpersonal violence. Their findings were that 42% of women who died from suicide had a history of exposure to interpersonal violence, with about 23% of them having been a victim of physical violence, and 18% suffering psychological violence, and 16% of them experiencing sexual abuse. Indeed, their findings also show that a large number of men who died from suicide had also been exposed to interpersonal violence, many of whom have had perpetrated violence within the 6 weeks prior to their death. Now, Haku in 2015 also conducted a study in northern Ghana with an attempt to establish health implications of partner violence against women. They found that out of 10 women, 7 of them experienced IPV in the past 12 months. And what is of interest here is that 13% of his participants had thoughts of suicide. So again, there is some kind of link between the experience of IPV and suicidal behavior. Now, it looks like all that I've said so far have been studies that were conducted among women. And now I have 2 studies that really have also been done among men to try to establish intimate relationships. So let's take a look at that. Khan et al. In 2021 conducted this study in order to examine how men's suicide attempts are embedded in the context of praxis of intimate relationships. They came out with a number of things, some of which are the men having troubles over the designated family providers' responsibilities, troubles emanating from second marriage, betrayal of loyalties, complications in non-marital relationships, and feelings of having no control over their wives. In fact, each of these things suggested that men who died of suicide or who attempted suicide found it challenging to balance their culturally expected masculine image with their intimate relationships. Another study was conducted by Goodman et al., and this was conducted in the year 2020, and it was done in Kenya. They also tried to establish an association, if there was any association between intimate partnerships, suicidal ideation, and suicide-related hospitalizations among young Kenyan men. And they found that really intimate partnership discord was salient to suicide ideation and behavior. They also found that men who reported their partner status as divorced had 4 times the odds of reporting suicide ideation. And men who used violent tactics to resolve conflict reported suicidal ideation. However, we can say that these 2 studies among men indicate that mental health outcomes related to suicidal behavior are not just found among women as victims, but also among men. But we can also say that for men, a lot of the outcome has to do with their cultural expectations and the cultural context in which they live. That is what is consistently related to suicide ideation or suicidal behavior more generally. So we can say that generally there is a kind of link or association between GBV and suicidality. And I mentioned earlier that the relationship or the association is not direct. The association is not causal. So we cannot say that GBV causes suicidality or causes suicide behavior. But there is an increase in risks for suicidality for victims of GBV, that is what it means, and various forms of gender-based violence, for example, physical, sexual, psychological, etc., may induce overwhelming pain or what we call psych-ache among the victims. And it is this pain or psych-ache that may lead to suicidal behavior. And GBV may also lead to a sense of hopelessness, which we all know is a risk factor for suicide. There could also be disrupted connectedness as a result of gender-based violence, which can culminate into feelings of loneliness, which is also a risk factor for suicidal behavior. In short, experiences of GBV may result in victims acquiring the capability for suicide. And as I mentioned earlier, some of those negative experiences may just push people into suicidal behavior. Now, we are in the times of COVID, and the pandemic has exacerbated the risk for women living in abusive relationships due to lockdown measures that may increase exposure to an abusive partner or other perpetrator. We can also talk about economic instability, threatening livelihoods, and increased levels of stress that we experience in this COVID era, and limited access, for that matter, to support services, which may all have heightened the risk of suicide. In fact, there are a number of studies that were conducted in 2020 and also in 2021, which indicate that usually there's an increase in IPV during times of crisis, and that COVID-19 has triggered unprecedentedly global health challenges, including mental health. In fact, Lyons et al. In 2021 specifically indicated that COVID-19 has had a tremendous impact on those living with IPV. So the high prevalence of IPV and non-partner sexual violence against women globally and in all regions highlights the need for us to work simultaneously on preventing this violence from happening in the first place, while ensuring that there is access to services for survivors. So in conclusion, gender-based violence poses threat to mental health, and it is therefore important for health and social services to assess mental health and specifically suicidality among victims. There is evidence that we have discussed up to this point, which underscores the need to address the economic and sociocultural factors and discriminatory gender norms and institutions that foster and perpetuate violence against women. Governments, civil society, and national and international organizations should show commitment to addressing violence against women. Mental health interventions, for example, should focus on alleviating psychological pain and hopelessness and improve connectedness. Relevant institutions, government, non-governmental organizations, civil society, should assess suicidality while interacting with victims of IPV, because we know that some of them are likely, to engage in suicidal behavior. Such institutions should also increase awareness and reduce stigma about misconceptions that are held about gender-based violence. They should also strengthen health, judicial, social, and other relevant systems to better respond to and prevent GBV. In addition, such institutions should also advocate for joint multi-sectoral response to violence against women. No one sector or no single sector for that matter will be able to prevent this type of violence from occurring. So we need to join hands to do that. We should also be ready to support national and local programs and strategies for prevention of gender-based violence. And lastly, we need to ensure that post-COVID-19 reconstruction efforts keep women at the center to strengthen their access to safe and paid unemployment. And also, they should aim for a world where no woman or no girl is denied her basic human rights and where they can live a life that is free of violence. Thank you very much for your attention.
Thank you so much to all three of our fantastic first half speakers. Apologies to delegates who had a few little glitches between the playing of the recordings. As I mentioned, some of you wouldn't have heard it at the beginning as you arrived late, but we decided to hold this as a meeting instead of a webinar to allow us to have breakout rooms, but that does create a few little glitches with muting and so on. So can I invite, we've got Angela, I can already see is showing her video and unmuted. Can I also invite Charity? Parveen's there as well. And also if our afternoon speakers want to join this part of the Q&A, they're very welcome, but equally we have the panel later in the day. Baru has already invited you to put your questions in the chat box. I haven't seen one yet, so I'm going to start with a question or two that I've noted down, and then by all means put your questions in the chat. Hi Charity, I can see you there. So something I thought came up in all three of your talks was the intersection between violence against women and childhood maltreatment and adversity as well. And I think each of the speakers spoke about how these things overlap in different ways. I think it's important to raise because I think in research there is quite a schism between researchers very interested in children and researchers very interested in women, and I don't think they always have enough dialogue. So I thought I would raise this question that violence against women and violence against children is all part of one issue that we need to have more focus on. Perhaps Angela, can I come to you first?
Yes, I think you're right. We don't do enough developmental work that shows, or developmental pathology, if you like, that shows how, as the child develops, the seeds of pathology sown in them. I shouldn't use the word pathology here, but it seems the simplest things to do. But the experiences in their lives, if negative and if not treated, that those pathologies or those difficulties may grow if there are no supportive structures to help. Think about a tree bent away from sunlight. If there's no sunlight shown on the other side to allow the tree to straighten up again. I don't think there's enough work done there, but as I was, I've been teaching and reading the literature quite clearly. When we see adults later in life, there's always a chance that there's been some kind of or violence in their childhood. And so it's good that you ask, how do we link the two? I'll leave Charity to answer that.
Yeah, okay, so I will just continue from where you left off. Really, I think that we do not have enough research in this area on childhood, violence. We don't have enough, and so that makes it difficult to have a kind of, clear-cut understanding with regard to how it relates to the, adult personality. So I think that it's about time that we devote, some amount of time for research among children, especially children who are in abuse and children who are experiencing violence. As I indicated in my presentation, a number of studies actually have linked, early exposure to violence to suicidality, and it's something that we need to follow up to understand clearly so that interventions will be planned for such children.
I would just add into it, I think that's an interesting question. And if we look at research, quite a lot of that already suggests that there's intergenerational transmission of abuse, and it's a learned behavior in many ways. So people who have seen abuse, either they learn to become perpetrators of abuse, or they accept kind of, especially for women in countries or in patriarchal societies where they have seen how women are treated, they just internalize that behavior and just accept that this is how it happens. And I think a lot of that also happens in what we see in terms of victimization of women or victimization of people who are abused, because we then transfer the blame to them and saying, well, they should have done this and they should have done that. So I think both of those things are quite interlinked with each other. As I said in my talk as well, that even in settings where you would expect people to understand, or you would expect people to ask questions about previous experiences, such as mental health settings and people who have come with mental health issues, you would expect that mental health professionals would like to ask about previous experiences. That doesn't seem to happen. And so I think this is where we need to start looking into it, that, there may not be any evidence. Not all people who experience abuse as a child become abusers themselves. Not all people. So it's not, you can't really generalize the things. There are quite a few things that we need to understand. But the majority of research suggests that. So I think it is important to explore those issues when we are dealing with victims of abuse or people who have got mental health conditions that are coming to it, so that we can actually deal with actual problem. Because otherwise it is like you're treating the symptoms but you're not treating the cause, and therefore the issue is never going to be eliminated. If, let's say, it was about domestic abuse perpetrators that you're dealing with, and if you haven't dealt with the issues that they have faced in childhood or earlier on and how they are affecting them still, and you're just only trying to manage their behavior at the moment, is just probably never going to work. So I don't know if it answers your question, but I think I was just trying to build on what we have already said. Thank you.
Thank you. Yeah, I think that probably brings me on to, oh, hang on, I've just seen a question from someone else. I was going to say, brings me on to thinking about the ecological model of violence and how there are multiple levels at which violence is both perpetrated and also perpetuated, and that there are community and societal factors perpetuating violence, and a huge part of that is patriarchal norms. I just want to see if any of the questions lead into that.
I think one of the questions is asked about, victim blaming, and when should we when should we blame the victim, or when should we talk? So I think this is a very, very sensitive issue, and I am not sure that we actually pay much attention to it when we say something. And it's not an issue which only happens in developing world. It happens all across the world. But I think people probably, you would see quite a lot of things on Twitter or Facebook or otherwise on social media, that how women are accused. If, for example, there's a rape, so it's like, why did she go out at that time? What was she wearing at that time? And when it comes to developing countries or countries, patriarchal societies where there are no laws are either not there, or if they are there, they're not implemented properly, then you kind of, see the manifestations in other sense. So recently there was an issue in, for example, Pakistan, where a woman was raped on a motorway while driving at the night time because her car was broke and she was there, and somebody just used that opportunity to abuse her. And a lot of discussion started off afterwards because the policeman said that why did she leave at the home at that time of the night, and why did she travel that? I think we do it from two point of views. One is that when we think there is nothing we can do about, or we find it difficult to talk about perpetrators, we talk about the preventive elements, and that's where you would see mothers or women talking to their girls about how to dress up properly and not going outside and all the rest of the stuff, because that's a protective element of it. But on the other hand, it is putting the blame on the victim for things that has happened to them. What victim blaming is never right, and we should always be looking at the issue that is under concern, talking about that issue rather than blaming the victim, and thinking of strategies as to how to prevent it. Because once we start victim blaming, once we start accusing the victim, we just kind of transfer our attention from the abuser to the victim, and therefore we see all of that aspects about what that person was wearing at the time, what they were doing at that time. And we also see that there are very little children, sometimes as old as 3 years old or even younger, who gets abused. So is it about their dress? Is it about, they are provoking it? Is it about any of those things? No, it's not. But then the attention turns to their mothers or their parents as to what they were doing about the children. They were not, so it's always in some way, shape or form, we talk about women, we talk about how they have raised their children, even for abusers. I mean, there was an interesting discussion yesterday about how the mothers have raised, what is the mother's role in in correcting behavior of abusive men. So somehow we, from every
blame
angle,
is always coming back to women.
Yes, somehow we find a way to bring it back to women. And I think the only way to tackle this is to talk about it, but to talk about it sometimes in a culturally sensitive way. So we do not make more enemies for our cause, but we develop more allies for our cause, so they can help us. Thank you.
Thank you. Yes, and Vanessa Okansi has raised a question, which also I thought came to my mind with a number of the talks, about lack of knowledge of the police. Even in the UK, there's a really big conversation now about inadequate police responses to violence. It's a huge topic over here, but Angela, you mentioned unhealthy attitudes by police. I think it's a big, I suppose police is clearly not the only remedy, but it's clearly one of the governmental agencies that has a role in responding to violence against women and girls and may respond adequately or inadequately. Angela, would you like to say anything about that?
Yes, in the sense that when those units were first set up, they were given great sensitization training, which included lawyers, psychologists, anthropologists, and so on. I haven't followed their continued training, but I do know that even then that original unit, of course, was dispersed as they were transferred into other units and so on. I think that the police and other government agencies that are the first responders in times of violence or gender-based violence need continual training. I mean, they are part of the society. They imbibe the same norms, trained or raised in the same norms that the victims and the perpetrators are raised in. And sometimes the pain of being associated or the pain experienced by the victims is difficult for responders to associate with. And so they kind of push that aside, they push them away in order to be able to continue their jobs and not burn out in the long run. But then the victims are re-victimized by that kind of response. So I think what is needed is the constant retraining of the responders, the police, the healthcare professionals like nurses, social workers, just need continual resensitization to prevent that. Not just that, but there are other structures that are usually not available in our countries. For example, when an abused woman leaves her home and needs a shelter, there are very few communities that have safe houses for them. When a child needs to be placed away from the abusive household, there's very few places that they can go for safety. So those are the gaps in services that we need to put in place. We've always relied on the extended family for an aunt to be able to step in and take the child or the abused mother and so on, but those structures are no longer as robust or even available as they used to be. And I think our kinds of governments around the world are needing to begin to take more of an active role in social services than they did before.
And actually, Charity, in your talk, you spoke about, I thought that was really valuable, the challenges of separation, because it's very easy as us professionals perhaps to see a woman who is in an abusive relationship and to think, well, she must leave. It would clearly be better if she did leave. And you've talked about the fact that actually leaving is also very problematic. And in especially a society where the woman may lack resources to be alone, or there'll be great shame and stigma. Stigma is the content of one of the questions we've received about being divorced or separated. There are actually a lot of barriers to women leaving, in that in some cases, women actually will return to an abusive partner, partly because of the nature of the abuse that reinforces itself, but partly also because her reality may not permit separation. I don't know if you'd like to say something more about that.
Yeah, so it's so difficult for women who experience gender-based violence or intimate partner violence to leave their relationships. And one of the key things that Angela mentioned is, I'll call it the lack of support system, for such women. Unlike the West, in our part of the world where we do not have the support system. So if you leave the relationship and let's say you are dependent, on your spouse, and you leave the relationship, you have children, where are you going to? So I think that women consider all of these things, and it becomes very difficult for them to step out of the relationship. And we know also of cases where sometimes in separation, they go through all the financial stress, they go through all the trauma and all of that, which impacts on their mental health. And so I guess that, many of them will just consider, okay, let me just, stay in the relationship and, just go through what I experience here perhaps is better than leaving the relationship or separating from my spouse.
And I think I'm just going to add into it, one of the frustrations which I have seen working with healthcare professionals, and I think it's the same with police and social services and other professionals as well, is that people not understanding why she's not leaving. So we have done everything and, we are trying to intervene, but she is not going to leave, which then means that next time they're not that willing or they're not that proactively trying to get into the situation to help the women. And I think it is really very, very important, as Angela was saying, training and retraining people, that it usually takes about 2.5 years, 2.5 years for someone to actually decide that, she's ready to leave. It's not an easy decision. There are quite a lot of things that women have to consider. So what is important is training health and social care professionals, police, judicial system to understand that, they're not going to leave the relationship for the first time when you have said to them, it's complex, it's not an easy thing to do. But every time you talk about abuse, every time you talk about their experiences, it does put a seed in, which helps them think through things. So it is that drip effect which helps in the longer run. So therefore we need to continue to do that and have patience and wait for women to decide it for themselves, rather than just holding our hands up and thinking, oh well, she's not leaving the relationship and therefore there's nothing we can do about it. So I think that is something which is really very useful. And also the importance of continuous training. I mean, we see within the healthcare setting with vaccination and other stuff now that, we've never thought of that people would talk against vaccination for polio or for chickenpox or any of those sorts of things. But you see now people are doing it because they have not seen those conditions in their lifetime. So they think it doesn't really exist. And there were a time when we became complacent and we thought that, well, everybody knows about the importance of these vaccines, so we don't have to tell anyone. The same goes for domestic abuse and other aspects, that even when we think people understand the issue, people are able to help, we still need to make sure that we are training and retraining and talking about those aspects, so it becomes clearer in people's head. Thank you.
And building on that need for continuous training, I think one of the themes also was it is very important to address the mental health needs of women, but equally the perpetration by men. It isn't always men who are perpetrators, but it overwhelmingly the majority of perpetration is by men. A few things were said about Charity, you said about the culturally expected masculine image damaging men's mental health. And Angela, you mentioned healthy beliefs about masculinity, and Parveen, you mentioned men's favour and against women. Often when you do research on violence against girls, people come to you with a question about men and you think, I wish people would talk more about the women. But I think people will inevitably ask a question about men, and perhaps that there's, there are people talk now about toxic masculinity, or men very much want to live in an equal society, but feel a great deal of cultural pressure to assert themselves as dominant. What's your sense of what is needed to make it easier for men to live as equal partners in relationships?
I think that, there are expectations of men by the wider society that add to this toxic masculinity. So things that would make it easier, I think, would be, of course, the empowerment of women to be to have access to jobs, equal opportunities for education, advancements, and so on, because then they would be earning as much. And the expectation that a man needs to be the provider at all costs, that would go down, and that the kind of pressure, expectations for financial support would come down. I suspect a good percentage of domestic abuse comes from the expectation of provision of resources for the family from somebody who is not equipped to provide. I mean, of course, there are people who have skills and good jobs who abuse their wives and children, but I mean, I'm just saying that a good proportion work we did in East Africa, for example, there were men's groups that had been given access to finance, how would you call it, savings and loan schemes and so on, had been given training and to rear their cattle and poultry and so forth, and vegetable patches. And their lives had changed. But I think that what they spoke about was, and of course their partners, their wives also, the wives were the ones that were began to be trained and had access to care, and then they were brought into the fold. And they spoke about the joy of no longer being asked for chop money as they walked through the door, because they had nothing to give in those days, and how they would then pretend to be angry and have a fight with their wives and then escape. And
I think I think it's important to understand the cultural context as well. So, you know, in many of the developing countries, the point that you raised is very important. And if you, how media portrays men and how media portrays women, what is the expectation? So quite a lot of, if you look at, if I'll use the example from South Asian media, it just, you know, how women are portrayed, what is a good woman, you know, who is a good woman, what kind of characteristics they have, and what is a bad woman. That narratives needs to change. And I think also about, you know, your question that, you know, what can be done with men, I think it is about training, and it is about knowing how healthy relationship works. I have always argued that, especially taking the example of South Asians, we do quite a lot with our girls. We tell them, oh, well, you know, when you get married, you are going to experience this, and, you know, that's going to happen. We want them to learn cooking so that they can live a better life afterwards. You know, there's no, but we don't really spend anything enough on men. We don't train them as to how to manage their conflicts, how to deal with their anger, how to deal with the issues which they have, how to maintain relationships. So the day when they get married, next day, the expectation is they're able to keep a balance between their wife and their mother and their sister. And they're then accused of, oh, you don't even know how do you manage relationships, and you don't really, whereas they don't know, nobody has told them about how to manage all of those things. So I think it should start from school, understanding how do you actually keep healthy relationship, what is a healthy relationship, how do you manage anger, how do you talk about issues, how do you solve those things. So I think all of that is very important, and the role of media, which is extremely important. And third, what Angela has said, in many countries, you would find that women do not even have a bank account. They do not have any ways of having money for themselves, or even keeping the money which probably they earn to keep it for themselves. So, you know, they probably would be working, but the money is going to go into the bank accounts of male family members, and they are the ones who are managing it. So economic independence and being able to work and being able to have your own livelihood is going to go far, far away. And as Angela has said, there are examples of interventions in many countries which have worked and which has shown promising results around that.
Okay. I just want to come in here and add on to what has been said previously. We did a lot of education, a lot of sensitization among women, but I think often when we have such education and sensitization programs, it appears that we leave out men. I think that is what Parveen is trying to say. We leave out the men, the boys, from a very early age, training them to understand what relationships are. We tend to focus only on the females or the women. And I think that is a big challenge. If we can broaden up, if we can include, men and boys in our interventions, I believe that will go a long way to bring this problem under control.
And just to sorry to take a point, we did an evaluation of a perpetrator program a couple of years ago in Doncaster, and one of the things that we learned is that when you talk to men about the impact of abuse on their children, that was the biggest precursor for them to think of changing their behavior. And why they changed it, because they didn't want their children to experience this. They didn't want this to have an impact on their children, and they didn't know how to manage various different things. So I think it's knowing what would help them change their behavior and getting them to the stage where they're ready to change it is something which is really important. And there is a lot of talk about the perpetrator program. Should we actually be focusing on perpetrators? They never change. But even usually there's about 40% success rate of perpetrators programs. And I think people who want to change should be given the opportunity to change it. And then there are other issues associated with it. But I completely agree that without engaging men into those discussions, having them as allies, having them on board, we can never be successful in eradicating violence against women or creating a successful environment for women.
I think I'd like to chip in here that it's also important to keep retraining the healthcare professionals in the issue of power, the power dynamics within relationships, because when you're within a even as you train perpetrators or you bring families together and you try to heal, you find that if you're not sensitive, you're taking sides with the powerful figures in the family who are the perpetrators usually. So it's really important that training of frontline staff is very much, power is very much a part of that training.
Absolutely, yes. And we have just a little bit more time. We've had a question about, are we doing enough in primary prevention, strengthening protective factors in individuals, strengthening protective factors in relationships and environments, and the capacity of service providers to deliver intervention. So you've already just said, Angela, about training providers and retraining. I suppose one thing I've thought in some settings where the prevalence of violence against women is very high is that many healthcare workers themselves are survivors or have perhaps even go home to an abusive household. And so there may be barriers to them asking because it's triggering for them as well. In settings where abuse is highly prevalent, how do we persuade health workers that this is part of their job, and then also support them with their own vulnerability too?
We don't have those around the world, those kinds of support structures for healthcare workers. I work in a teaching hospital, and we have doctors in training at all levels, nurses, psychologists at all levels. And I look at the women, sometimes I think I need to set up a training group that goes year round, where practitioners of all kinds can come in and talk about the things that impact them. And I think that I suspect in the next 5-10 years, all big health institutions will have that kind of groups that, just help us deal with our own emotions as we do healthcare. Yes, I'm glad you asked the question.
Yes, I don't know whether coronavirus has sensitized some health organizations to the value of health workers and also their fragility and risk of burnout, but maybe that's an optimistic idea that they will invest in the well-being of health workers. How about this wider question of primary prevention, Charity and Parveen? Is there anything you would add to this issue?
I think we don't really do enough. And if we look at the healthcare workforce, 70% of the workforce is women, healthcare workforce across the world, and 60% of them are nurses, and then midwives. So when you have a large majority of the women workforce, you would think that, you know, many of them would themselves be experiencing abuse or being in abusive relationship and stuff like that. But the organizations do not in which they work in, they probably wouldn't necessarily have any ways to support if these women come and say, well, you know, this is what's happening with me, you know, are there any issues which can be, what can be done to support them to deal with their issue. And we've talked about the clinical supervision as to when you are dealing with those sensitive issues, we expect healthcare professionals or police or lawyers and other people. I think we just expect them to get on with it. We don't provide them the ability to debrief or to talk about their own feelings. And therefore, then people develop their defense mechanism where they tend to block the thoughts about it, don't really think through those things. So I think there needs to be those kind of provisions where we talk about those aspects. But with regards to your question about do we do enough, I don't think we do it enough. So I've got and that's not necessarily related to any particular country. So I've got a Future Learn course which I developed last year, which was aiming at healthcare professionals and telling them how to be able to support victims of abuse. And there are about 20,000 candidates on that course, people from all across the world. And it's so upsetting to see that experiences of women, whether they're coming from America, Mexico, or a very small village in Kenya or India, they're not different. You know, when they talk about the issues which they face, or the you know, when walking home at night time, or what they have to deal with in terms of work, it's distressing to see that none of the countries, or there's no single place where you can say that, you know, these are much developed and experience of women could be quite different there. So no, we don't do enough. I think there is, we have started talking about it. We have developed screening tools, and we are doing various other bits where we are able to identify, but then we also need to see what is it that we are expecting those people to do it. Dealing with something like domestic abuse or gender-based violence needs a multidisciplinary approach. We can't focus on just one profession or discipline or to be able to do it, because if a healthcare professional identifies somebody who's experiencing abuse, they wouldn't have the capacity to put the person behind the bars. They wouldn't have the capacity to provide shelters for those women. So it is the housing, police, legal system, and all those different elements that need to work together. And as you've said earlier on, looking at the ecological approaches, that, you know, it's the whole system approach that we need to think and develop, and also think about the issues which those people providing services are experiencing, so that they not only are able to provide effective services, but they can look up for their own mental health as well. So I think that's work in progress, and more needs to be done about that. And continuous discussion like this today is something which is really very, very important.
Thank you. And Charity, the final word to you.
Yes, so in talking about primary prevention, then we are thinking about, you know, stopping the problem from occurring at all. So yes, we are not doing much when it comes to primary prevention. We need to be more open. We need to engage in more sensitization, more awareness creation among both males and females about the dangers of violence, this kind of violence, and the outcomes, the mental health outcomes that we have discussed. So yes, we are not doing enough. We haven't done enough, but there's room for improvement. We should focus on more, programs that aim to stop this form of violence from occurring.
And I think this is the objective of things like Building Back Better that say after a big event such as a pandemic, we have an opportunity to reassess our services and what we provide. And, I would love nothing more than to see investment in preventing all kinds of things, including mental health problems, rather than waiting for people to feel very unwell and then spending much more money and resources on treating their illness. I'd much rather we prevent them from happening in the first place. Unfortunately, in our setting, funding decisions always seem to be to cut the prevention programs and to cut the women's centres and then pay for it later at much higher cost. But that's a more pessimistic point of view. Thank you so much, everyone, for your fascinating contributions. I hope everyone in the room enjoyed it. We've maintained a number of delegates hovering around 180 all morning. Fantastic. Before we go for a lunch break, we want to go into breakout rooms to have the chance to find as close to a real conference as we can. Have that feeling of who else is here and do I have anything in common with them, who we share an interest, or actually with completely different perspectives. As I said, Baru and I met at a different conference in a breakout room, and now we're organising this great conference. So we hope that chatting to each other will be a really worthwhile thing to do. I'm just posting in the chat now a suggestion of things you could talk about in your breakout rooms. Of course, you can talk about anything, but we thought you might like to introduce yourself and your experience of GBV and mental health, what you've got from the morning, what you might take forward in your own setting, and what something like iVAMHN could do for you, and what kind of other events you'd like to see, and is there any way you and the people in the breakout room might perhaps be collaborating together. So I suggest you, the post I've just put in the chat, you copy the text because you're not going to remember and it won't go with you into the breakout room. And in a moment, Seyram is going to put you into breakout rooms, and according to our schedule, we're going to give you, I'm just going back to my timetable, we're going to give you until basically 40 minutes to have a chat with each other. And after that, 20 minutes break. So it's going to be until 12:10 in Ghana and 1:10 in London, and every other time zone, you're going to have to work that out. But basically 40 minutes breakout room, then 20 minutes break, and we'll be back at 12:30 in Ghana and 1:30 in London for our next speaker. Hello, everyone. Thank you so much for coming back after the break. I would say more than 100 people coming back after the break is a great success, because I know it's very normal to have people feel tired after lunch, and it was a very short lunch break. So really, thank you for coming back. We're so pleased to have you. And it's great that you did, because the next two talks are absolutely fantastic. And after the talks, we've got a brilliant live panel discussion coming up as well. I think there are a few things I wanted to say to you about iVAMHN, because I know a lot of people missed my introduction because connection stopped you joining exactly on time, but I think I will just save it for the very end of the conference, just to say you will get an email after this asking you to please tell us if you'd like to join the mailing list, and also give us a small bit of feedback on the conference so we know what went well and what we should improve for the future. And we're doing a survey on relationships and well-being during coronavirus, and it would be completely fantastic if you would fill in that survey for us. So we will include that in an email to you afterwards. So please don't ignore our email. And we'll now move on to our next two talks, and have a think during the talks if you have questions, and put them in the chat box, because we'll be having a panel discussion afterwards.
Hello, I truly hope you are enjoying the event as much as I am. Our next speaker is going to bring us even more insight and unpack the issues further. He is in the person of Dr. Adjorlolo. He's a senior lecturer at the University of Ghana and currently the head of Department of Mental Health Nursing. Dr. Adjorlolo's research interest centers on mental health with a focus on maternal mental health. He was a recipient of Queen Elizabeth's Advanced Scholarship to investigate mental health issues in pregnancy and post-delivery. This is a subject in which we should all be deeply interested because of the negative impact that mental health during that period can have on multiple generations simultaneously. We are very honored to have him as a guest speaker today to talk on gender-based violence and maternal mental health. Enjoy the presentation. Thank you.
Hello, everyone. I'm excited to be part of this conference, and I'm delighted to be presenting on intimate partner violence and maternal mental health. My name is Adjorlolo. I'm a lecturer at the University of Ghana and the head of Department of Mental Health Nursing at the same university. In this presentation, I'll be focusing on the definitions, the forms, and the prevalence of intimate partner violence, which is sort of a component of gender-based violence discussions that have been going on over the years. Then I will look at specifically IPV and maternal mental health issues. And we'll narrow down to look at the detection and addressing of IPV in childbearing women. And then we look at how do we go forward from here based on what we know. Next is definition. What exactly do we term intimate partner violence? And I must be quick to add that there are several definitions and there are several concepts relating to IPV, but I chose this one by Dismerias et al. Because then it contains the key ingredients that can be found in other definitions. And in this particular context, we refer to IPV as any behavior within a current or past intimate relationship that involves behaviors or that involve activities that pose significant threats to the victim's physical, psychological, social, economic, and spiritual well-being. So with this, you will see that then a composition of what constitutes intimate partner violence is just great, and it's so much of them. So wherever we pass, wherever we find ourselves, we are able easily to dictate the import and the consequences of intimate partner violence around a range of behaviors and other stuffs. There are several forms of intimate partner violence, but what we have here and what we'll be discussing briefly is physical abuse, emotional abuse, sexual abuse, financial abuse, and of course, in this era of technology, then it is important to focus on this unique kind of abuse, which has been quite neglected in the literature. When you say physical abuse, you're making reference to abuse that involves direct contact with the victim. And this abuse takes several forms, including hitting, pushing, inflicting bruises, holding or restraining the person, and dragging or pulling the person by the hair. Okay, so if you see any of these behaviors, then clearly we're dealing with physical abuse. And this one of is the abuse which is very evident and can be seen easily compared to other forms like emotional abuse, where some people even refer to it as psychological abuse. And this abuse, although it's very devastating and very painful, the challenge is that it is extremely difficult for people to identify this sort of abuse. The forms emotional or psychological abuse takes include threatening someone or intimidating the person. Sometimes by constantly criticizing the person and by insulting and acting in a way that belittles the person, all constitute what we term as emotional abuse or psychological abuse. Unlike physical abuse, this hits the person's emotions. And so you may not say physical injuries, for example, on the body, for you to think that the person has been abused. And in most settings, abuse or violence is construed to be physical injury. So in the absence of such injuries, that is impossible and sometimes extremely difficult for people to report that they have experienced this form of abuse. But as I stated earlier on, emotional abuse can be extremely devastating to the victims. And so it is important we pay attention to this one. In addition to sexual abuse, which takes various forms, including rape, including assault, and all those things. And in this particular context, we making sexual abuse to refer to forcing a victim to have sexual intercourse. And this is narrowed in this context because of the people that we are dealing with. In this case, you're talking or making reference to pregnant women or women in the perinatal or postnatal period, okay? So the woman who is pregnant, the husband is insisting that although you may be in pain, I will still have to have my way through with you. That can be traumatizing and emotionally painful for most pregnant women to actually endure. Financial abuse is also another type of abuse, and this takes several forms, but the commonest we have are one, withholding money from the person. You know, the person needed money to do 1, 2, 3 or A, B, C, D, but for some reasons you withhold the money and not giving the money back to the person or giving the money to the person to meet those needs. Or sometimes you have access to the person's financial reserves or the person's savings, and then you systematically try to deplete that reserves or that savings for the person by buying things or spending it in a manner that is unapproved. And the victim gets to know of the financial status, that can be traumatizing. So financial abuse is one of the ways in which intimate partner violence manifests itself. And then the last, which of course is born out of the technology world, is how we are able to use technology to constantly, for example, track people's location, monitor people's communication, and post things on Facebook that sometimes people do not like and are not interested in, and wouldn't want, for example, such information to be on social media platforms. So all these things constitute what intimate partner violence is. And over the years, we have had the discussion as to these behaviors and how they can be traumatizing and how the consequences can be devastating for almost everyone, but most importantly, people who are extremely vulnerable. And in this context, we are looking at pregnant women or women who have delivered and have a burden of nursing their babies or have a burden of nursing their pregnancies until they're able to deliver. We do know over the years that intimate partner violence is very prevalent in the world, in Asia, in Africa, and even in high-income countries. It is interesting to note that one form or the other of intimate partner violence do exist, except that the prevalence is notoriously high in low and middle-income countries. And to be precise, reference here is being made to Africa and Southeast Asia. And of course, in the study by WHO in 2013, then you see that compared to high-income countries, the prevalence of IPV in Africa and Southeast Asia is significantly higher than those that we have in high-income countries. If you go to country-specific data, perhaps the prevalence that we know could be higher. And I'm going to take you to Ghana. Existing data, for example, shows that 38.7% of ever married women have experienced one or different forms of violence. And this as we see, appears to be gender specific, that the majority of the victims of violence, and particularly the one that occur in intimate relationship, is women, okay? And in Ghana, it also emerged in 2012 by the Domestic and Victims and Violence Support Unit of the Ghana Police Service. Shows that in 2012, then there were 12,000 plus cases of various forms of violence inflicted by partners. And as I noted before, the most of these victims are females, and the perpetrators then to be males, or appear to be males. 2 years after that data, it learned that the rate has increased to 17,000 plus, which means that there were more the cases of domestic violence and intimate partner violence is not reducing despite the interventions that have been put in place to encourage reporting, to promote awareness, and also to let people understand the legal and the psychological implications of intimate partner violence. Going forward, then we see that IPV can occur in pregnancy and in the post-delivery periods. These two periods we can refer to as a perinatal period. And most importantly, the perinatal period is a very vulnerable period. One, for several reasons. One, in the case of pregnancy, then there is a developing fetus. So any attack, any behavior which endangers the mother also put the life of the developing fetus at risk. And after delivery, then whatever the woman goes through, the child who also is breastfeeding will bear the brunt of the consequences of that behavior. But this is also the case that although we have cases of intimate partner violence in pregnancy, the literature is clear that that behavior does not start or really starts in pregnancy, meaning that for most people, the cases of violence and the cases of abuse do happen even before pregnancy, except that it can be stopped during pregnancy or it can continue during pregnancy. But clearly, then it's extremely difficult to have violent tendencies towards a partner by a virtue that they are pregnant. But in most cases, then abuse and violence are something that predicts getting pregnant. But then how prevalent is intimate partner violence in pregnancy? Statistics from the literature shows that it ranges from about 1% to 21%, okay? But what is also clear is that if you compare the statistics of intimate partner violence in the pregnancy period to other periods in a woman's life, it is clear that IPV in pregnancy is very low. And it's very low for reasons accounting for this low prevalence. We may look at that briefly in the next slides, but what we do appreciate is that this is low, and although it's encouraging, we rather expect that it does not exist so that the life of the mother and the life of the baby will not be put at risk by virtue of these abuses. Okay. If I take you back to a study from WHO looking at beating in pregnancy or physical abuse in pregnancy, it is clear that then the distribution varies as a function of the country in which data was taken from. If you take, for example, Peru province, and you see that the rate is higher compared all the way to a city in Japan. Okay, so again, this data confirms the earlier discussion that issues of IPV or cases of intimate partner violence are predominantly higher or significantly higher in low and middle income countries as opposed to high income countries. And even so, if you take low and middle income countries, then there are also variations in the distributions of cases of intimate partner violence, right? Now, and earlier on, I stated that the prevalence rate of intimate partner violence in pregnancy is low compared to a woman's or other periods in a woman's life. So in fact, what we're trying to say is that pregnancy could act as a moderator of IPV. And in this case, pregnancy or the dynamics of intimate partner violence may differ in pregnancy. Most importantly, physical abuse or physical violence will be minimal in pregnancy period as opposed to emotional or psychological abuse. Because it's easier for anyone to understand that if I beat this woman who is pregnant, I may hurt not only her, but also the baby. But it is possible we may not know that hurting her psychologically will also hurt the baby. And so whereas physical abuse may be less, but it is possible that other forms of abuses that are not direct could be higher. And in this case, emotional or psychological violence. So if there is a relationship that traditionally is characterized by physical abuse, in the course of the pregnancy, that is possibly likely to change, or that could change from physical abuse to emotional or psychological abuse. So in effect, then the state of pregnancy is changing the shape and the nature and even how IPV manifests in families. And this is extremely important, that we don't expect necessarily that what was before pregnancy will still continue during the pregnancy or even after delivery. There could be changes. And this insight is instrumental as we strive to conduct an assessment and most importantly, to identify people who could be at risk or who are victims of IPV, and that you intervene appropriately in their situation or in their condition. We do know clearly, and of course not only in reference to pregnant women or in post-delivery women, we do know globally that the consequences of intimate partner violence extend beyond physical effects to include psychological or mental health issues. And the most common mental health issues that correlate with IPV in pregnancy are depression, anxiety, suicidal ideation, stress, post-traumatic stress disorder, and panic disorders. Okay. Of course, there could be other ones like sleep difficulty and the rest, but predominantly, then depression and anxiety appear to be the most common mental health issues that are reported by pregnant women who also have history or who have experiences of intimate partner violence. We may not immediately appreciate the consequences of these mental disorders on pregnancy, but we do know that when a woman is depressed, a pregnant woman is depressed or has anxiety issues or has suicidal tendencies or suffer from any sort of mental health condition, these disorders contribute to maternal and child morbidity or mortality. And this can happen in several forms. For most people, or in most cases, then there's a possibility of postpartum psychosis. And in fact, the literature is pointing to the fact that experiences of IPV during pregnancy could potentially contribute to postpartum depression as well as postpartum psychosis. So whereas we may not see the effect physically as compared to physical abuse, but it is interesting to note that studies have established that depressive symptoms, anxiety symptoms, and other mental health conditions in pregnant women are major contributors to infant and maternal mortality and morbidity, which again emphasize the need for us to pay critical attention to these issues during the period of pregnancy and even after delivery. We do know that the issue of abuse is very common, but then why is it difficult for pregnant women, for example, or women who have delivered to leave their relationship or to leave their problematic relationships? Then falling from what others have found, it is clear that several reasons explain why they do stay despite things getting bad or worse on a daily basis. One of the expectations is that things will get better. And for a pregnant woman and for a childbearing woman, then issues of resources and responsibility for herself and for the child could be so much that she's not able to handle. And as a result, would prefer to live in the battered relationship just for the sake of the children. And in some contexts, the religious and cultural beliefs also keep people in battered relations. Religiously, or in a predominantly Christian society, then you have divorce as something that the good Lord frowns upon. And that also is the case in other religions. And then for cultural beliefs, it is the case, for example, that if a marriage breaks down, then it's the woman who is not able to actually hold the marriage together. So again, this can also influence a person's decision to leave. And a fear of being hurt or being killed could also make people leave in a better relationship, notwithstanding the consequences that this brings to them. But then the period of pregnancy and post-delivery are extremely important in our effort to address issues of intimate partner violence and mental health issues in this population for several reasons. One, when women are pregnant or they have delivered, they are very sensitive physically and emotionally. It means that should anything happen to them, they take it extremely serious. For a pregnant woman, for example, because of the concern of the baby, they take actions should they experience any behaviors that they think will affect their child. So in this case, if they are battered by their husbands, for example, for the fear of the developing fetus or the baby, they can quickly rush to the hospital and seek support. So in fact, in this period, then there is an opportunity for pregnant women or post-delivery women to contact and establish bond with the health facility. So this is a unique opportunity for health professionals and others who are involved in promoting maternal mental health issues to actually do their best to ameliorate and improve the well-being of these pregnant women. Compared to this period, then prior to or before pregnancy, mostly contact is not as frequent as possible, but from pregnancy going, then the contact is frequent, and it's possible as they come to the facility frequently and regularly, there is a possibility that they may open up and speak truly to what the issues are in their homes with respect to experience of violence or abuse in the house of their partners. Then, clearly, we now know that intimate partner violence is common in pregnancy and also in post-delivery women. They've established that the consequences are enormous, and that include that of mental health. And although the immediate impact is not known, we do acknowledge and we do know that mental health issues in pregnancy and in post-delivery period contribute to infant, child, and maternal mortality and morbidity. But the question is, why is it difficult to detect and address issues of intimate partner violence? And this discussion, unfortunately, has been going on several years, and several interventions have been proposed and implemented. But it's also very clear that addressing or detecting intimate partner violence is extremely difficult. Why? In the context of pregnancy, then there are a multiplicity of factors, and these factors include those belonging to the victims. And here, some victims, some pregnant women have poor help-seeking behaviors. They prefer to keep things to themselves, and they prefer to also protect the image of their families, the image of their marriages. They prefer to protect the image of the community and society they live in. And by so doing, they hardly voice out whatever issues, whatever troubles they're experiencing. As I noted before, sometimes a break in relationship is attributed to the woman's inability to keep the man. And for most women, then it makes sense not to speak out, although things may not be going the way it is expected. Then there could be professional-oriented factors pertaining to the health professionals themselves, which we shall look at briefly, and then those relating to the system. Are there structures, are there processes, are there mechanisms in the systems, in the hospitals, in the facilities that allow the victim, that allow the pregnant women, that even allow the health professionals to detect and actually respond adequately and appropriately to the mental well-being or the well-being of this pregnant women. If we take practitioner barriers or health professional barriers, then what stands out is the issue of awareness and education. For most people, then the training they've had as part of being professionals does not include issues on intimate partner violence. And indeed, if you sample the training curriculum of most institutions providing health trainings, you hardly come across discussions of gender-based violence, domestic violence, and intimate partner violence in the curriculum. So most people finish school and they're not aware of what constitutes intimate partner violence and how they can help people who are actually going through that process. So lack of awareness and education is one of the practitioner barriers to identifying and providing help to women who might be victims of intimate partner violence. And then not wanting to open a Pandora's box, not wanting to have the woman say things that a health professional is not ready to listen, not wanting a woman to start something that the genesis is quite long, and so it is impossible to finish it within that shortest possible time. So as a result, then there's a tendency to just keep quiet and provide the routine healthcare services to pregnant women without showing much interest in whether they experience violence and how we can support in addressing these people. And even for those who have identified clearly that there is evidence of violence, they are not certain as to how to intervene. And as I said, because they haven't received the requisite training and education, they're just not certain how to intervene. How do I report it? Who do I report it? What happens next when I report? Would I be called to give evidence? And so all those things could be barriers that could prevent these people actually from intervening. And then there's also the tendency to safeguard a person's image by not listening to something that itself can be a distress, that itself can be a stress to you, the individual. So in this case, listening to someone's experience of traumatic or intimate partner violence could be traumatizing. And so a health professional will not be interested in trying to start that discussion because they may not be emotionally stable and strong enough to accommodate the issues that may come as a result of the experiences. And then, of course, time constraints. And this is particularly important in low and middle-income countries where health infrastructure is poor, where human resource is low. And so you have few nurses, few doctors attending to a large number of patients. There's not enough time to spend discussing issues around intimate partner violence that are thought not to have immediate impact on the pregnancy or on the post-delivery woman. So again, these are just some of the practitioner barriers which can affect opportunity to actually help people who suffer from intimate partner violence. But that should not be so. And we hope that as part of this engagement and as part of this conference, the take-home message is for health professionals to assume the responsibility of detecting and taking steps to address issues of intimate partner violence in the pregnancy or post-delivery period. And what can you do? One, the basic thing is to conduct screening, and they can screen these women. Unfortunately, there are a range of screening tools that have been validated for the purposes of detecting women who are victims or have experienced intimate partner violence. These tools may not be developed in our context, but the fact that they are not developed does not mean that we are able to use them in, let's say, in Ghanaian context. All we need to do is to adapt those ones, subtest these tests to psychometric validation, and then move on from there. Then as health professionals, they are expected to also understand who is at risk of becoming a victim of intimate partner violence. So in this case, as a little bit of profiling of the patient is extremely important, and which means that we must know which factors particularly correlate and which factors particularly increase the person's risk of becoming a victim of intimate partner violence. Once we have an understanding and appreciation of those factors, we are able to immediately support a person, a pregnant woman, for a more detailed assessment and intervention when it is necessary. And then we are, as health professionals, they are expected to assess the level of danger that a person has in the house, in the community with regard to experiencing intimate partner violence, and give appropriate and safe advice. Sometimes it becomes necessary that they connect and refer the person to local agencies. And in our context in Ghana, for example, then the social welfare system and the police system becomes extremely important if any referral for additional actions and interventions will have to be taken. And then when necessary, identify other family members or children who will be at risk of becoming victims of intimate partner violence. So as I noted before, health professionals have the mandate to understand women who will be at risk. Okay, and although there are no single profile of abused women, we do know from the literature, we do know over the years that poverty, for example, low educational background, not being married and yet pregnant, and alcohol consumption and prevalence of alcohol, and having unwanted or unplanned pregnancies actually increases the risk that a pregnant woman, a post-delivery woman, will experience some level of intimate partner violence. So if you are a clinician, you are a nurse, you are a doctor, and you have clients and you're able to have this background information, then even they don't tell you what they have gone through or they are going through in the hands of their partners, based on this data that we are presenting, you are able to begin the discussions about whether they feel belittled, whether they are being supported, whether they feel harassed, intimidated by their partners. So as the discussion begins, then you see that should those behaviors persist or exist in the life of the pregnant woman, they are bold and they are confident to disclose this to you. So profiling, again, is the first step in identifying at-risk women, in addition to administering screening tools, which we have several of these tools. And I said before, they may not be validated in the Ghanaian context or other localities, but getting them in Ghana and other regions should not be a difficulty, because then there are easiest way to validate these tools using some psychometric strategies. And then this could be part of the resources that are used to provide healthcare services in the antenatal and postnatal services for pregnant women. In effect, health professionals have the mandate to empower childbearing women who are victims of intimate partner violence. They have the mandate actually to contribute to the prevention of this behavior. And in all, they have the ability and the mandate to empower childbearing women. And to empower is an acronym which stands for empathic listening, okay? Making time to properly conduct or document your findings about the pregnant woman and issues of intimate partner violence. You provide information about intimate partner violence to this pregnant woman. There are people who do not know that this behavior constitutes abuse. There are some people who do not know that this behavior constitutes violence. There are those who don't know that this behavior has these negative implications on my well-being and that of the baby I'm carrying. And so it is important as health professionals to begin to provide salient information about intimate partner violence to pregnant women, offering them options and choices. This is what we have. Would you want us to go to the police? Would you want us to go to the social welfare system? We don't want us to report to your family. Would you want your family to take action? So make those options available and help these women make choices that they deem best for their situation. When necessary, you have to work with an abuse specialist and encourage planning for safety and support when the life of the pregnant woman is in danger or will be at danger. And lastly, you could refer to local resources for support and for interventions. To actually move forward and to ensure that there is such a systematic effort to push the agenda of intimate partner violence screen identification in the pregnancy period and also in the post-delivery period, then this presentation is proposing 3 major shifts. The first one is the integration of IPV detection and response system into antenatal and postnatal services. My research in Ghana over the years have uncovered that issues of mental health have a less important role in the antenatal and postnatal services provided to pregnant women. In fact, the focus has always been on those physical aspects of pregnancy, the physical diseases in pregnancy, like hypertension, diabetes, and those are that have been the focus. The subtle ones, mental health, and those other ones that women will experience, such as intimate partner violence, are not included, are not parts of the regular antenatal services that are provided. So going forward, and just as we are doing for whole mental health integration package at primary health care system, we should consider intimate partner violence in our context where the prevalence is high as a crucial element that must be part of the services rendered to pregnant women at antenatal and postnatal services. The second one is there's the need for institutional re-engineering and capacity building. In fact, in series of studies we have conducted, it is clear that nurses, for example, indicate they lack the capacity, they lack the skill, they lack the knowledge on issues about mental health. And so they are not able to provide the support needed to these pregnant women. And of course, if you have no idea what mental health is and how mental health presents in pregnancy, you are not in a position to provide the best of the care. The institutions need to be re-engineered. They need to, for example, make provisions for mental health treatment centers or units in their various hospitals, and also build a capacity of nurses and doctors and all those who work with pregnant women or post-delivery women, so that they are able to render basic services such as counseling, detecting, screening, and then making referrals to expert services where this is necessary. And the last strategy is a bottom-up interventions, which means that intervention that will be instituted and measures to actually get intimate partner violence issue detected and intervention of it should be something that should also be taken in consultations and in discussions or with data or input from the pregnant women or the post-delivery women. It would be inappropriate to adopt a top-down approach where few people decide that this would be good for pregnant women or this would be good for post-delivery women. Their input and insight is extremely important. And I'm hopeful that if we do this, if we implement this, then we are able to bring down the canker of intimate partner violence, which is eating deep into the fabrics of the pregnant woman and also the post-delivery woman. Together, then, with these interventions, we are able to restore the well-being, we are able to advance the well-being, and then the growth of the mother and the child in a manner that makes them enjoy humanity and dignity as institutions have been set up to advocate. On this note, ladies and gentlemen, I say thank you very much for listening to me. I welcome any feedback, comments, and opportunities for collaborations by contacting me on my email address as I have it here. Thank you very much, and I wish you all the best.
Thank you so much for continuing to be a part of this conference. We are so pleased you're here and we hope you're having an amazing time. Our next speaker is Dr. Nayreen Daruwalla. Dr. Daruwalla holds a PhD in social psychology and has worked in gender-based violence for the last 20 years. She has developed the program of prevention of violence against women and children at SNEHA, that is the Society for Nutrition, Education and Health Action, a non-profit organization working on public health issues in Mumbai, India. She serves as director for SNEHA, leading the programs on prevention of gender-based violence with communities in urban and informal settlements. With a background in clinical psychology, her expertise is in conceptualizing model interventions to prevent violence for adaptation and replication in low and middle income countries. Particular focuses are on mental health and gender-based violence, counseling interventions, community development and response, and changing the institutional response to gender-based violence. Her work includes partnerships with University College London on research projects and on replication and adaptation of the gender-based violence model with government and non-governmental organizations in India. Her interdisciplinary background and research have contributed to the discourse on gender-based violence in South Asia. Currently, Dr. Daruwalla has designed the scope, content, and measures of a complex intervention for primary and secondary prevention of gender-based violence in India. She is the principal investigator from SNEHA on a cluster randomized controlled trial to prevent violence against women and children in urban settlements of Mumbai. Additionally, she has managed projects on sexuality and health of adolescents and large public engagement projects involving art and science. What more can I say? Help me welcome Dr. Nayreen Daruwalla. Thank you.
Hello, everyone. Thank you for giving me this opportunity to speak on violence, abuse, and mental health. I am Nayreen Daruwalla. I am from SNEHA, an organization working on Mumbai on issues of health and gender-based violence. SNEHA works on a continuum of care approach, and there are 4 major verticals of SNEHA. Maternal and newborn health, which is on improving quality of care in public systems, enabling women, pregnant women from communities to avail health system services on time. The other flagship program of SNEHA is Child Health and Nutrition, which is on severe management of moderate and severe malnourished children in the communities and linking them up with the system. The third program is Empowerment, Health and Sexuality amongst Adolescents, wherein the program works with adolescents from 11 to 18 years of age, giving them information on sexual and reproductive health, gender equality, and providing vocational skills. The prevention of violence against women and children is the oldest program of SNEHA, and we work with a very comprehensive approach where we work in many communities of urban settlements in Mumbai. We provide primary, secondary, and tertiary interventions to survivors of violence and abuse. So this program, as I said, it started in the year 2001 in one of the largest settlements in Mumbai called Dharavi. So if you look at Dharavi, this is an aerial view of Dharavi, and if you look at it, there are about 7.5 lakh population living on a 1.6 acre mile. So you can imagine how dense the households are and how adjusted the living conditions are. Sanitation and hygiene is always compromised in these slum areas, and it's always difficult for women because women are surviving on day-to-day basis in these areas in a very compromised setting. We run 7 community-based counseling centers in Mumbai, which provide counseling and crisis intervention services to survivors of violence. 3 hospital-based counseling centers, and we have kind of collaborated with public hospitals in order to run a women's OPD. We call these centers women's OPD because women's outpatient department, because we really want women who access the hospital to come to these OPDs and ask for help. And we also run a one-stop center which is in a large public hospital in KM Hospital in Mumbai. So what are interventions on violence, abuse and mental health? There are, globally, there are 3 types of interventions categorized when you talk about violence against women. And they are primary prevention, which is actually doing primary prevention work in the communities and preventing violence. So our primary prevention work happens in all these communities where we work. Secondary prevention is prevent violence from continuing or escalating. So once the violence has happened, how do you really stop it and prevent it from escalating more? Tertiary prevention deals with more minimizing the impact of violence, restoring safety, mental health and well-being, and also looking at legal systems. Very often what we find in our communities is women do not even have an idea that if they are undergoing violence, then there are mechanisms for them to seek legal help. This is the social model, and this is the model that we follow when on our program on prevention of violence against women and children. So the first and the most important component of our work is providing crisis, counseling, and extended response. I think when women don't understand when they undergo violence, our experiences, women access our counseling centers only and only when all their resources are depleted and they have nowhere to go. That is the time they access our counseling services. So providing that kind of unconditional support and working out solutions with her, because the mere fact that she's come to you and she doesn't know what to do and has no solution. So that is provided through our counseling services. The second aspect of our work is community mobilization, and I think anyone who is running violence programs is very important for them to know that unless and until community mobilization is not done, how will you ensure the uptake of counseling services? Because when we started our work in 2001 in a hospital, it was in an extension center of a big public hospital, and it was amidst the community. We did not have many women reporting violence to us. And within a year, when we heard about cases of murder and burns happening in the community, that is when we realized that unless and until the services are not advocated enough, and unless and until not much work is done with communities on them understanding abuse, violence, and other related issues, there is not going to be any uptake of the counseling centers. Also, social norms. Women in our society, in the Indian society, are very much kind of, their whole approach to this is affected by social norms. Asking for help means dishonoring the family. Asking for help means putting the dirty linen in public. And the notions of good and bad women often get challenged, because I think one of the norms in our society is if you are a good woman, you will tolerate violence. And you will come to a point where families will say, oh, you are a good woman because you have tolerated violence, you have played your role, and you have dispensed with your responsibilities very well. So community mobilization we do through group education and individual volunteerism. Group education is taking, forming groups of men, women, and adolescents, and running a series of group sessions with them where they learn about violence, abuse, law. And not only that, I think it is important that they learn about how violence is so interconnected to their daily life. So our 3-year module is Aware, Act, and Lead. Create awareness within the group. Second is on how they can take action in the communities when they see violence. And the third one is building leadership. And of course, institutional response. The program works a lot with the police, healthcare, and legal system, because unless and until you do not work with these systems, how will you provide a comprehensive response to the woman? As an organization, you can provide counseling, you can do family intervention, you can do community intervention, but when it comes to actually seeking the law and seeking help, it's very important that programs have to work with police, healthcare, and legal systems. And advocacy in a country like India, I think women's groups' rights have advocated for ages, and we do see some changes happening. So today, I also want to talk about the burden of mental health. And when we talk about mental health, I think there is a lot of focus on abnormality. And the abnormality is, any kind of mental disorder, which is, of course, which is also a burden. But when we connect mental health to abuse and violence, I think it is very important to remember that there are millions and millions of women who remain in extremely difficult conditions and circumstances in their lives, and that probably affects their mental health. So I would like to talk a bit about the double burden. How does this double burden on mental health comes about is because of 3 main reasons. The first one is gender differences in roles. I think in a place like India, there are very clear-cut gender roles. And all over the world, in fact, I mean, there is a lot of discourse going on about how women's labor, especially at home, is not accounted for at all. We see that in our work all the time. 50 to 60% of women who have reported violence to us in our counseling centers have also reported that the violence has been on account of expectations of roles and responsibilities. So I think that's a major determinant for the double burden. The second one is gendered exposure to stressors. I mean the stressors of urban living, the stressors of every day getting up and thinking of getting water, not being having a private space for toilet and bathing. I think, and of course, along with that, pressures of surviving. And in urban informal settlements, I think survival is so important that is a huge matter. How do you survive? You're not earning enough. You don't have so many government facilities. How do you really survive? The third is gender differences in responsibility. As I said, very important, because the responsibilities, and in COVID times, again, we saw the same thing, that when the women were at home, We did a study with about 1,000 women who had approached our counseling centers, and we asked them that because of COVID, has there been a change in your roles and responsibilities? 70 to 80% of women said that it has overburdened us. At least earlier, when other family members used to go out, we had our own coping mechanisms to manage and feel better. Now we don't even have that. So we are almost working all the time. So the gendered nature and response to conflict is intimate partner and domestic violence, which we see a lot. And I think here I would like to make a point that then when I started work, when I started the program, there was a lot of emphasis. Even today, there is a lot of emphasis in the media about sexual violence. And when I say sexual violence, I'm talking about sexual violence by non-intimate partner, which is considered rape or sexual assault. What we have seen in all these years is, and we have data for about 14,000 women from 2001 till now, and absolutely unequivocally for all these years, what we have seen is that we have 80% of our women who have reported violence have reported intimate partner violence and domestic violence. Sexual violence being reported is about 8 to 9%. So I think it is again a big question to answer that yes, of course, sexual violence is, I think what happens is sexual violence is more gory and it comes across and the media projects it much more, but women who live in their homes are sexually violated all the time and they are unsafe all the time, but it doesn't just come out. So what are the associations between violence, abuse and mental health? One, this is from our experiences in the last 20 years, women who live in very difficult conditions, women predisposed to mental illnesses and who have undergone violence. So a lot of women who have had mental illnesses, the relationship with violence is even more complicated because the mental illness is a debilitating factor and that comes in between the relationships and family and that leads to more violence. Women with a history of trauma, women who have had PTSD earlier on account of violence or any other reason, these women are much more vulnerable to mental health conditions. Women with mental illnesses are also likely to be involved in unsafe and abusive relationships because the discretion that one should have, maybe that is a little bit lacking. And we see these women are often into unsafe and abusive relationships. And they continue to be in these abusive relationships and they are not able to break the cycle of violence. The double burden of mental health and violence further complicates service provision a lot. It's not easy. It's not easy when a woman comes with a violent history and also a mental health problem presented. It just becomes very difficult and complicated because there are so many issues involved when you provide a service. So this is our step care approach, wherein we at the most bottom level we carry out, as I said, community mobilization, and through community mobilization, our volunteers are able to identify, provide the first response and refer women to our counseling center. The second level is where our counselors help the women, they talk to them and they figure out what violence interventions could be provided. And along with that, we also have clinical psychologists and a psychiatrist who helps when the counselors do an initial assessment and find out that these women require further help. and it could be just help from a clinical psychologist, then these women are referred to the clinical psychologist. So our data shows that 44% women fall in the category of common mental health conditions, 40% fall in the category of moderate health conditions, and there are about 16 to 17% which fall under severe mental health conditions. And mind you, the 16 to 17% is a bit higher than the global figures of severity or the national figures of severity of mental health. So I think one can deduce that violence and abuse plays a big role in mental health. So what types of problems women have reported to us? Intimate partner violence, domestic violence, and sexual violence by non-intimate partners. These three categories are reported the most. What are the interventions that the counselor does? Providing crisis counseling, carrying out crisis intervention, taking her to the police, or intervening with the family if it is required immediately. Because sometimes the woman is driven out of the house, or there are many other issues. Or the woman has a mental health condition and she is very aggressive, and it's difficult because the family doesn't want to accept her since she's very aggressive. So there are many different variety of issues. Noting the history of violence, understanding the problem of the client, need assessment of the situation. I think one important aspect of the counselor's role is to assess what is the situation around her. Because we talk about social determinants of health. And when we talk about social determinants of health, I think it is very important that we look at her overall situation that is leading to this kind of a problem. Exploring options with the survivors, formulation of the problem. The counselor decides with the client, with the survivor, how will she address the problem? Will she take her to the police first? Will she intervene with the family first? Or she is very, very upset, so she will take time and she will first calm and quieten down the woman and then plan other interventions. I think this is all what the counselors do. What are the main interventions once the crisis counseling is done? I think psychoeducation, role education, marital counseling, couple counseling, family counseling, and legal counseling. What do women present with when they come to us with mental health conditions, depression, anxiety disorders, post-trauma? We see a lot of PTSD in women. Personality disorders also is quite substantial. Substance abuse and psychosis. These are the main mental health conditions that we see in women. What do we do? So I think the first thing to do when women access us is doing a safety assessment, figuring it out whether the woman is safe in her home or not. So that's the first thing, her safety assessment of her environment. Second is suicidal risk assessment, whether she is prone to suicide, or if she is very suicidal, then suicidal management immediately is very, very important. But also include talking to the family members, letting them know. The third is we assess the survivor on patient health questionnaire PHQ-9 on her levels of depression. We assess her on anxiety. We also administer a brief hope scale to understand whether at present her coping is avoidant or approach, and how does the counselor formulate a plan in a way that she can move her coping from avoidant to approach. We also administer a well-being scale and empowerment tools. When we look at empowerment tools, we look at social empowerment, family empowerment, and economic empowerment. I think this is repeated again. Mental health interventions are suicidal risk assessment and assessment of self-harm. Suicide risk assessment is done to understand the intensity and self-harm, because these are most difficult and also very difficult for a counselor, because the woman is very suicidal, the woman is constantly inflicting self-harm. How do you calm her down? What hope do you give her so that the woman can calm down? What can the counselor say so that she can at least understand that something better will happen in her situation? Conflict diffusion, again, is one of the most important mental health interventions, and both these interventions were done a lot in COVID times on our helpline, because we couldn't physically go and talk to the women, but they were all done on our helpline. Assessment of mental health conditions and establishing the severity, again, very, very important, because you need to ascertain on the spectrum where the woman is, and referral to psychiatric intervention. We generally, our approach is to send women to the public hospital for psychiatric intervention, but in COVID time, we had to move psychiatric intervention on the helpline. What are the other mental health interventions? Goal setting for therapeutic alliance with the survivor, because unless you do not do, and these are all done by the counselors. These are not done by clinical psychologists. Our counselors are regularly trained to do these initial mental health interventions. So therapeutic alliance, most important. Work on management of behavioral difficulties. There are certain behavioral difficulties that, for example, the husband beats her and the woman gets very angry and beats him again. But these behavioral difficulties are very important to be worked upon. Work on mood and anger management, psychoeducation to the survivor, which is very, very important. Systematic transfer of knowledge and awareness of the situation. Role education, what is her role vis-a-vis roles of other people in the family. And most important is work on emotions of the survivor. And the survivors present with a varied range of emotion, mainly fear, anger, guilt, sadness, and hostility. And these emotions are quite difficult to handle. So our counselors are actually taught on how, when the first time the woman comes and when they are formulating a problem, which of these emotions emerge to be the most kind of worrying for the woman, the counselor takes that track and talks to the survivor. Now, these are some of the mental health interventions which are done by a clinical psychologist: relaxation techniques, systematic desensitization, adaptation of cognitive behavior therapy. And all these therapies and all these techniques which I have listed down here, I think one should remember that it is impossible to establish a very therapeutic alliance with survivors of violence. They are not interested. They are more interested in the situation getting better, and they access counseling centers with that objective. So I think taking a whole cognitive behavior therapy or a rational behavior therapy and planning therapeutic sessions with the survivor doesn't work. What in our experience has worked is a mix of techniques, and these techniques are used as per the clinical psychologist's discretion on what the survivor needs the most. So these are some data that I wanted to present. In the year 2018-19, in 1 year, we had 5,267 clients who came to us. The main presenting concerns, as you see, the most important were denied resources and physical violence. Made to leave home is also quite high. So these were the main presenting problems due to which they came to the counseling center. Mental health concerns is again 12%, sexual violence has increased 14%. And the number of concerns, so number of concerns were, one concern was women who came with only one concern was 24%, but women who came with 4 concerns were 10%. So we all know that forms of violence are not mutually exclusive, and the numbers present that. The case category, as I said, intimate partner and domestic violence always rates very high, and the others slowly become much lower as compared to intimate partner and domestic violence. Emotional forms of violence, emotional violence was the highest reported. After that, economic, physical, and neglect and control. Women have been talking a lot about neglect and control, and women have been talking a lot that neglect and control impacts their mental health a lot. Risk assessment. We did a risk assessment, and in the risk assessment, as you can see, assaulted by partner is really, really high, 58%. Assaulted outside home is 17%, and escalation and violence is 13%. Threat to risk, again, threat to the client is highest, followed by threat to kill the client and threat to the family. Home risk, pressure to move out of the house is high as compared to thrown out. So it's generally done very subtly with the survivor. Child risk is threat to the child is quite high, and often abusers use this strategy to keep control over the woman. Mobility risk, isolated by family is high, 10%. Isolated location, they've been put in a location where no one can meet them, see them, is 8%, and held against will is 3%. Perpetrators using drugs and alcohol is 23%. Mental health concerns are very high, 23%, and client suicidality is again 14%. When you look at the overall risk, standard risk is 56%. Medium is 38%, which is not less. And if this is a medium risk, our counselors need to act very quickly so that there is not much more harm done to the woman. And high risk is 6%. Crisis counseling in the first week provided almost 80% needed, and suicide risk assessment is done with 57%. So that means that these women who have come to us have shown, some kind of traits of suicidal ideation or suicidal attempt. And again, it links to the mental health condition of the woman. This is an interesting slide on, we do when the first time the woman comes, or the first time if the woman is very distressed, then we do not do the assessment. We do it the next time, and then we do it later after 6 months and after 1 year. And what we really, as you can see over here, the women have both anxiety and depression. Women have moved from severe moderate categories to more mild and minimal categories. It happens because they get support from the counselors, the clinical psychologists, and of course, we cannot claim that we are able to kind of redeem them from a complete mental health condition, but I think the counselors' intervention over a period of time really helps them to move into better categories of mental health. Yes. So I just want to end here with 1 or 2 learnings that I would like to talk about. And I think one of the biggest learnings that we've had when we run violence and mental health programs is that it is very important that interventions are integrated together, because if the interventions are separate, the woman may feel stigmatized and the woman may not want to seek help if we talk about mental health per se. So that is very, very important. Secondly, these interventions can happen on a bedrock of community mobilization. So community mobilization and the buy-in of the community members is very important if we want the uptake of these services from survivors of violence. And the third is these interventions take a long time. So I think if organizations want to work on gender-based and violence program, gender-based violence and mental health programs, I think it is important to remember that we need to make a comprehensive package which is delivered effectively, efficiently in a short period of time, and not really kind of, have a package which is delivered over a period of 1 year, because you will lose women. Women will not come back to you. So I think when a survivor comes the first time, if the whole setting is done, generally in our experience, 3 sessions are kind of enough to work on her violence situation and on her mental health situation. So with this, I end my presentation, and I'm really hoping that, people who are watching this presentation would have gleaned something about our interventions and the work we do, and wish you all the very best and happy to answer the question. Thank you very much.
All right, thank you very much to both of our speakers. It has been a very insightful presentation, 2 very insightful, inspiring presentations, and we are so grateful to all of you. If Dr. Adjorlolo and Dr. Nayreen Daruwalla are here, if you could unmute yourself. There you are. Thank you so much for coming. Yes, and Dr. Adjorlolo, if you are here, could we please see you as well? Dr. Samuel Adjorlolo, are you here? Okay, let's just
Yes, I'm here.
All right, thank you very much. Yes, Dr. Adjorlolo, let me just start with you. In view of the exalted position of motherhood within our settings, why is there still an increase in intimate partner violence? Could you share your thoughts with us, please?
Thank you very much. Good afternoon, everyone listening to us. Yeah, so then several factors could be responsible for the increase in intimate partner violence issues in our context. As we have noted, there has been population dynamics as well as socioeconomic changes. And one of the key issues that we speak to often is poverty and low socioeconomic background. That background actually sort of serves as a barrier for empowerment and for emancipation of people from cultural norms and from societal norms that sort of nurse and also nourishes intimate partner violence. Due to poverty, people are not able to report the fact that they've been abused by their partners. If you do that, a whole family can be against you, a whole community can be against you, because in some instances, then the husband or the man is a breadwinner of the family, and that support extends also to the external family system. And so if you have any issue against a man, then it's like you have issue against the entire family system, and nobody is willing for such things to happen. Then the other issue has to do with education.
Dr. Adjorlolo, I think your microphone is off, yes.
Right, the other issue has to do with education. Now the question we ask is how many people are even aware of what constitutes intimate partner violence? And this is a critical question we need to ask. Maybe if we superimpose literature from the developed nations, where it is clearly stated what intimate partner violence is. In our context, if a woman receives, let's say, or is denied money by the husband, to what extent would that be regarded as an abuse? Okay, if the woman wants something or the man depletes the woman's resources, for example, economically, would that be treated as an abuse? And would that be considered as an abuse? So although these things are there, then we are able to differentiate between normal behaviors and abnormal behaviors. So when they meet professionals and they do ask them whether they do experience those things and they said yes, then you realize that then a lot more people will be reporting on the experiences or their experiences, which then add up to the prevalence. So as to why it is increasing, then to me, it's a matter of poverty and socioeconomic background as well as education that is sort of influencing this, because it makes it difficult for cultural norms to be changed because people are socializing in a manner that is intergenerational. Thank you.
Thank you very much, Doc. Dr. Daruwalla, do you want to add anything to that? Thank you.
I think what my colleague said is interesting. And when we work in communities, there is a lot to work on changing norms, and all our work in all these years has been, whether it is one-to-one counseling session with the woman, or whether it is really bringing about awareness in the community. I think we need to really focus on how norms can be shifted. And if the norms are shifted, not only with communities and women, but also with systems, service providers who are providing services to women, like the police, the healthcare, because there's a huge bias with the systems also when it comes to GBV intervention. So I think if we can look at these interventions and behavior change in norms, it might, that's what we see in our work in urban slums of Mumbai.
Okay, thank you very much, Dr. Daruwalla. In your work in the urban slums, are there any particular community mobilization strategies that have worked for you that you think can be scaled up or applicable in other settings as well?
Yes, I think one is when you enter a particular community is not ready to accept you. So, there are gatekeepers who will not allow you to do any interventions on violence. So one way that we have entered communities is we have often referenced cases, for example, rape cases or sexual assault cases, domestic violence cases, which have come in the media. And referencing through these cases, we have spoken about how safe are your communities, how safe is your family. And I think that is one approach which appeals to everyone. So even the gatekeepers who do not want to talk on violence, I think when we talk about safety, security of women, and family as a unit, that is the time when communities start relenting and allowing us to carry out community mobilization strategies. And the second, once you have entered and once you have kind of built a relationship with the community, what we see is violence intervention cannot be done single-handedly. So one woman or one man, you can do a bystander intervention, but definitely if violence interventions have to be done, then you need to bring them in group. So group education has been a very successful strategy. And from the group education, individual volunteers emerge who again work in groups or who again work in pairs to help other women.
All right. Thank you very much. We can indeed learn from your example. Dr. Adjorlolo, do you think Ghana is a fertile ground for the, for us to work with some of these community interventions like the cultural gatekeepers? I'm talking chiefs and people who are actually on the ground. Do you think they would be, receptive to some of these community mobilization interventions that Dr. Daruwalla is speaking of?
Thank you. So as she rightly noted, changing societal norms, changing cultural norms is the most promising solutions to addressing issues of intimate partner violence. And we do understand and duly appreciate that then there are traditional leaders, there are opinion leaders, there are queen mothers, there are chiefs, and there are elders who are sort of custodians of our cultures, okay, and other things that we learn through socialization. Therefore, if there's a need for any change, they themselves should be the first change agent. And to make them the first change agent, you need their involvement and consent. And that is where issues of stakeholder engagement or community level engagement becomes extremely important. So if you're able to engage them and they accept the concept, then the next focus is to make them ambassadors of change. And then we know that in our settings, our elders, our leaders, our chiefs, our queens are revered. So once they come as change ambassadors and they are preaching a particular language, it's easier for the next generation to actually be transformed along the changes they are proposing. So community level interventions can work effectively in Ghana, but then again, we must understand what have worked elsewhere and how it can be adapted to actually suit our context. I'm aware of some community level interventions that are addressing gender-based violence, but there are still more that we can do in Ghana.
Yeah. Thank you. There's still more we can do in Ghana. And as Dr. Daruwalla said, one person or one system is not able to change. You need all the systems and individuals, groups, organizations, institutions working together. What do you think we can do in Ghana to actually influence policy? Because in your presentation, you stated the very devastating consequences of maternal mental health or maternal mental ill health on the child health as well, in terms of child mortality as well. And this feeds right into the SDG goals, which Ghana is signatory to. So how do you think we can influence policy in terms of things like, integrated perinatal mental health care? How do we do that so that government will put money where their mouth is in terms of training, in terms of the curriculum? Or do you think there are other institutions that have more of a say in such things than the government? And how do you think we can go about it generally?
Yeah, our approach to this phenomenon that we are addressing now could be examined from different angles. The starting point, essentially, from my point of view, is to have a comprehensive data, okay, that details, for example, the prevalent nationwide, not pockets of surveys or individual studies done across different settings reporting different things. If there's a systematic effort, for example, by government, by the research community, by development partners to understand the scope of the problem culturally, socially, then that's the starting point. Then the second thing is, what do we need as a solution to the problem? So if we uncover all those things, then policy briefs and policy discussions can actually start from there. At the moment, as I noted in my presentation, screening for intimate partner violence is something that hardly happens in our settings unless the woman comes with physical symptoms, like she's beaten, you can see the scars, the bruises, then they begin to ask questions. Otherwise, what is often neglected is psychological, emotional, financial, and those other ones whose consequences are sometimes devastating than even the physical ones. So we need then to have a data that speaks to the issue and then local solutions that can be, it is from there that issues of integration. In that case, we know how to even train the nurses, how to train the doctors to deliver what kind of intervention and at what level, what is the referral pathway from here, where do we go? So then a whole system. So formative research is the first step to actually convince government that there's a problem and that we need to address it. And to do that means we need development partners to support with funding. Since they have been those funding our projects and the rest, then they can come in that state. Once we're able to generate the evidence, we are able to start engagement with government and all relevant stakeholders with regard to integrated perinatal health services.
Okay, thank you so much. Finally, Dr. Daruwalla, let me just ask you your thoughts on that as well. In your capacity as director of SNEHA, how you are influencing policy. Does India have a policy on gender-based violence and mental health, and how to cope with it, any protocols, and any final thoughts as well?
So yeah, so India has ratified the CEDAW Convention, right? And the CEDAW Convention is to eliminate all forms of violence. But of course, we are not far away from eliminating all forms of violence in our country. I think when we talk about policy, what the government really wants to hear is, and this is our learning for the last many years, that they do not want to hear only about women's policy. So what happens is, if you go to the government with recommendations on for women's health and only women's health, government do not want to hear. They're completely blunted to hear about it. But if you go with an approach and say that, look, if you do this with the woman, her child, her family, her extended family is going to be benefited, then of course, you can at least, the government will relent. So I think one is that we all need to think through, because I'm sure the situation is not very different in other countries, on how we position ourselves when we talk about policy. We have had acts like Protection of Women Against Domestic Violence. There are some Indian penal code sections on dowry and harassment. But yet again, I think the dowry harassment section is very it doesn't look at other circumstances. And again, it is very problematic to implement for the service providers. So all in all, I think it is important that positioning of GBV needs to be looked at differently. Secondly, with the health system, I only want to say that we are in the health system and we have been in the health system for the last 21 years. But what is again important is, if you carry out routine screening, you are not going to be able to really get cases of gender-based violence. What is really required now is, how can we train doctors to do sensitive probing? Not for all, but for women where they see signs and symptoms, do a sensitive probing. And second very important thing is, do a warm referral. What happens is, in institutions, in healthcare institutions, doctors are overburdened with patients. So what they do is, they inform the survivor and say, okay, there is a counseling center, go there. The survivor is not going to go there. She doesn't know where she's going, what is happening to her. So I think the doctors can do warm referrals, take some time, difficult for doctors, yes, or maybe the doctor can assign a nurse or a resident doctor to explain to the woman. I think these strategies will work.
Thank you so much. Dr. Adjorlolo, we don't have so much time. We've gone beyond our time. So I'm just going to give you the chance to give us your final words.
Right. Thank you very much. To actually confront the issues of gender-based violence or intimate partner.
I think your sound is a bit low.
Yeah.
Is it okay?
Yes, Thank you.
It's okay.
Yes, it is.
Right. So it is clear that there is a lot of violence against partners in Ghana. Within this month, media report alone suggests horrifying cases and incidents of intimate partner violence. And in most cases, then women are at risk. So if you want to move forward as a nation, then a holistic approach that address issues from all risk factor levels becomes extremely important. But then, of course, there's always going to be a starting point, and that is the socialization. Unfortunately, most gender-based violence solutions tend to ignore men whilst attempting to empower women. To me, that is the wrong way to go about it. Since the men appear to be the perpetrators of intimate partner violence most often, then it behoves that interventions target them rather be more relevant in the long run than those that are focused on the women. Because when they change their behavior, but a woman change the behavior and the man changes, the man is socialized in the same manner as before, then you haven't done anything anyway. Going forward, the second point is interventions focusing on our socialization process, one, so that boys are growing into men and have orientations about what a woman is, how a woman needs to be treated across all peers in our lives. And that to me is my final thought for this discussion. Thank you.
Thank you so much. I think the helplessness of women also empowers men to abuse them in some cases, but thank you for that point. Dr. Daruwalla, please, your final comments before we go.
I think my final comment is here for students and people who want to really get into this kind of a field. This field is challenging because your rewards are very few, but at the same time, I think there is a big need for more and more people to work in this field and give attention to public health interventions on gender-based violence. I think it is no more only a matter of the woman's right. We often get caught between, oh, it is a woman's right and how can we make it a public health concern? But I think in my experience of working for so many years, unless we do not make abuse public and unless we do not work with all the constituencies and all the systems, we cannot bring about a change.
All right, thank you very much. On that note, I would like to thank all our speakers for a very powerful, insightful presentations and discussion. We are really glad you were here. So thank you. Over to you, Roxanne.
Thank you so much, everyone. I'm not going to take any more of your time. I think we're incredibly privileged to have these brilliant talks, and I think it says it all that almost everyone who started the day with us has stayed with us all day, which is the highest compliment with online conferences and people being so busy. So thank you everyone for giving your time. In the chat, you will see I've put a short link for telling us if you want to join the mailing list and share your feedback about today. We have this survey of relationships and well-being during coronavirus that we would really appreciate you filling in. We're on Twitter, and we're recording the talks from today. We're going to stitch them together into a nice long YouTube video, and once that's happened, we've got permission from all the speakers, we will let you know where you can find that. Thank you so much, and I think everyone just take the take-home points that we've just heard. You know, all of us have it in our power to follow the WHO Lives framework, listen, inquire, validate women, enhance safety and support them. All of us can do that, whatever our role. Have a good day and thank you for joining.